Now, today we will be talking about diuretics. First of all, we have to define what is a diuretic, right? And especially there are two terms which are sometimes used interchangeably. There is a term called natriuresis, diuretic, natriuretic, and there is a term which is called diuretic. Many people use them interchangeably, but literally they mean a little difference. Who will tell me what is natriuretic agent? What is meant by an agent which is natriuretic? Yes, please. Right, very good. Any substance or any drug or any agent, when it introduced in your body or in biological system, it increases the output of urinary sodium, right? It causes increased loss of sodium in urine. So any agent which increases the loss of sodium in urine, it is called natriuretic agent. But when we strictly define diuretic agent means any agent which increases urine output. So it means anything which increases the sodium output in the urine, that should be considered natriuretic agent. And anything which increases the urine volume, that is called diuretic agent. Now, most of the drugs which are used, which actually are natriuretic, when they produce some degree of natriuresis, it means there is increased loss of sodium in the urine. This extra loss of sodium pulls extra water with it into urine. So it means natriuretic drugs are diuretic as well. It means natriuretic drugs are diuretic as well. Right? Now, let's go into detail that what is the normal urine output, what is normal renal blood flow, and how nephron works, right? First of all, we'll talk about, let's suppose here is your cardiovascular system or circulatory system, right? Now you know circulatory system is supplying the blood through arterial tree to the all body and every organ, including your kidneys. You know kidney is made of a lot of specialized tubes which are called nephrons. How many nephrons you have in one kidney? You never counted it, too busy in your life. How many nephrons you have in one kidney? About 1.2 million. He has been counting it. He is right. So, in two kidneys, you are having about 2.4 million nephrons. What I really mean that you are millionaire as far as nephrons are concerned. An average adult person has somewhere between 2 million nephrons. What are nephrons? These are very specialized tubular structures, epithelial tubes, present in the kidneys which are concerned with urine formation, right? And of course, when anything which increases the urine output or which increases the sodium output, that must be working on nephron. It means natriuretic agents or diuretic agent alter the function of the nephron in such a way that there is increased sodium losses in the urine or there is increased water loss or volume in the urine. So first of all, we must see how a normal nephron works, right? First we'll talk about how a normal nephron works, what is the normal volumes of urine produced, how normally sodium is handled by different segments of the nephron, and then we'll talk about how different drugs alter the function in different segments of the nephron producing natriuresis or diuresis. Okay, we start with a very, very fundamental concept that let's suppose this is your cardiovascular system and out of your kidney I bring one nephron here. Out of the millions of the nephron, I bring one nephron here. Every nephron has one filtration unit, right? And to this filtration unit, blood flow is coming, right? Now this blood flow, this is glomerular capillary tuft and this is Bowman's capsule. Together they make the glomerulus. And basically what is glomerulus? This is a area into which blood comes into kidney, right? And it is having on the other side Bowman's capsule, the very earliest part of the nephron, and it acts as a filtration unit. Now what really happens when blood is coming to this area, some part of the plasma, some components of the plasma are basically filtered into nephron, right? Now from here, what happens? There are different parts of the nephron. This earliest part of the nephron is called proximal convoluted tubule. Of course, it is made of different type of cells, right? This is epithelial tube made of epithelial cells. Here is loop of Henle. This is the descending part of loop of Henle. This is the ascending part of loop of Henle. This is the hairpin turn. Of course, this is in near cortical area, and this is in the medullary area. And again, this is also made of, what are these things? Epithelial cells, right? Now, what really happens that in this area, it becomes wide, and we call it thick part of ascending limb of loop of Henle, this part. And of course, it is also made of different type of cells, right? As you know, all the nephron is made of an epithelial tube. Is that right? These are all epithelial cells. Now we have drawn some parts of the nephron. What we are seeing that when the fluid is filtered from here, first it appears into Bowman capsule. From there it passes through the proximal convoluted tubule. Then it goes through descending limb of loop of Henle. Through the hairpin turn, the fluid moves again towards the cortex, and initially there is, what is there? Thin part of ascending limb of loop of Henle. Then there's thick part of ascending limb of loop of Henle, right? From here, then what really happens? This is, what is it? This is distal convoluted tubule, and eventually this distal convoluted tubule will end up into, collecting duct. Of course, again, it is also made of cells. Now, there are a few important things which we have to understand, that what are the basic functions of nephron. As we know, first of all, it should have a filtration unit. Fluid should move into Bowman capsule. Now, fluid will be moving through this tube, and eventually a part of the fluid reaches up to the end of the tube, and that part of the fluid which appears at the end of the tube, this is called urine. This is called urine. What is urine? Urine is the fluid which appears at the end of the tubule. Now, one thing which we have to learn is that what is the amount of blood flow per minute to the kidney. Now, let's relate a very basic concept. What is the amount of blood flow to the kidney? Out of that blood which is coming to kidney every minute, how much is the plasma? Out of the plasma, how much fluid is filtered? Out of that filtered amount of the fluid, filtered volume of the fluid, how much is really going back to the body? How much is further added to this area? And eventually, out of this total fluid, what really appears here? We'll talk about this thing. First of all, number one, the urine is formed in three processes. Process number one is, filtration. Process number one is filtration. The fluid is filtered. Process number two is, on the way when fluid is going along the nephron tube, a part of the fluid is reabsorbed and going back to the body. Is that right? But some of the fluid is actively, you can say some of the components, right, or some of the substances are actively secreted into tube, nephron tube. Now, so what we can say, all the fluid which really come into this tube is by through sources. All the substances which come to the lumen of this tube is through two sources. Main source is filtration, plus some substances are coming through secretion. So we can say that this tube is receiving the fluid mainly by filtration process and some substances from secretory process, right? So this total amount of filtered and secreted substances in the tube minus the substances which are reabsorbed, and what is left over, that is called urine. Now let's come to the let's calculate the things minute by minute. Right now, every minute, how much blood is going to your both kidneys, right? Again, it depends on your cardiac output. and so many other factors. In normal physiological situation, heart is producing how much cardiac output per minute? 5 liters per minute. Usually, in normal circumstances, your heart is pumping how much blood into arterial tree every minute? 5 liters. Out of this 5 liter, we say 20% goes to 20 to 25% goes to kidneys. It means whatever blood is being pumped out of the heart, about 20 to 25% is going to the kidney. Out of this 5 liter, if we make that 20% of the 5 liter, it should become how many liters? 1 liter per minute. So what did we learn right now? All of you know heart is pumping how much blood per minute to your arterial tree? 5 liter. Out of that, how much blood is going to your renal vasculature? 1 liter. That is 1 liter. So now we can say your kidneys are perfused approximately with 1 liter of blood every minute. When 1 liter of the blood is passing through it, all of the good students know that out of this 1 liter, there are cells and there is plasma. Right? Cells are about 40% and plasma is usually about 60%. So rather than total blood flow, if we talk about the plasma flow, so out of 1 liter of blood, how much plasma will be coming? Yes. How much plasma per minute will be passing through it? 60% of the blood. Right? You see, I have said it that out of 5 liter cardiac output, 1 liter is coming to renal system. Out of this 1 liter, 40% is cell, 60% is plasma. It means how many ml are cells? 400 ml are cells and 600 ml is plasma. So if I ask that through your all nephrons, if this nephron is representative of all your collective nephrons, right, how much blood is passing through this area entering to glomerulus, we say per minute is 1 liter. But out of that blood, how much is the plasma per minute? What is the plasma flow rate? That is 600 ml. So we can say that about 600 ml plasma is passing every minute through your renal glomeruli. Out of this, how much really filters out? Everything does not. Again, look, a part of it goes into Bowman capsule and rest of it moves forward. Is that right? Look here. This is afferent arteriole. Here it is efferent arteriole. And we can say afferent arteriole bring 1 liter blood every minute to glomeruli. Or we can say 60% of that blood, that is plasma, afferent arterioles bring 600 ml plasma flow every minute to your glomeruli. Out of that, some is filtered and other is going to the efferent arteriole, which will break down into pericapillary networks and other vasa recta. These are the capillaries which are around the nephron to reabsorb certain substances and secrete few. Now, if it is 600 ml entering into this every minute, how much is really filtered? Answer is approximately 20%. Answer is approximately 20%. Now 20 is very important here. Out of cardiac output, how much blood come to kidney? 20%. Out of plasma flow per minute through glomeruli, how much is really filtered? 20%. So if we say 600 ml is passing through it, if 10% is the filtration, of course this filtration usually is having very little proteins or practically no proteins, right? So it means protein and cells don't pass through it in a normal healthy kidney, not in any significant amount, especially proteins. So we can say the thing which is really filtered is water of the plasma with its soluble substances which have molecular weight less than albumin, right? Small solutes. Now again, I said how much will be filtered? 20%. Now, out of 600 ml, if 10% is filtered, it means every minute 60 ml is filtered. If I say every minute 20% is filtered, it means how much is filtered? 120 ml. So all of you must be knowing that every minute how much fluid is filtered. Yeah, every minute how much filtrate is appearing in Bowman capsule? 120 ml, 120 mLs. Is that right? Per minute. We also call it glomerular filtration rate, GFR. Now, what we have learned up to now, we have developed a relation between the cardiac output and renal blood flow, between the renal blood flow and the renal plasma flow, and glomerular plasma flow and filtration. Is that right? So if I asked you right now, normal person, what is the cardiac output per minute? 5 liters. Out of that, how much percentage goes to kidney? 20%. What is the 20% of 5 liter? 1 liter. So how much blood is going to your kidneys per minute? 1 liter. Out of that 1 liter, how much is plasma? 60%. So 1 liter is the blood flow through the kidney per minute. What is the plasma flow? 600 ml. So if we say 600 ml plasma is passing every minute through your glomeruli, 20% filter down and 80% goes to the peritubular capillaries and other capillary loops like visa recta. Now, so how much is really filtered? 120 ml. So a good doctor knows that on average, a normal person's kidney nephrons are receiving 120 ml of filtrate every minute. Is that clear? Normal person's glomeruli, or you can say Bowman capsules, right? They are receiving how much filtrate? 120 ml per minute. Now, out of this 120, look here. Now it is passing through the tube. This filtrate is passing through the tube. Lot of substances are reabsorbed back to the blood. Some substances are added by the secretory process. So, what really happens as fluid is passing along the nephron, as this filtrate fluid is passing along the tube, we call it tubular fluid. What is this? Tubular fluid. Here it is interstitial fluid, right? This is intracellular fluid. Here it is tubular fluid. What is this? Intracellular fluid. And what is it? Interstitial fluid. And what is it? Blood. Is that right? So there are 4 types of fluid right now here. That filtrate is passing through the tube as tubular fluid. What is tubular fluid? Right? Tubular fluid is filtrate plus secreted material. And on the way, when tubular fluid is moving, some substances are reabsorbed and some substances are added. It means the epithelial cells in the wall of the tube are processing the luminal fluid. They are processing the tubular fluid. And when they are processing the tubular fluid, on this process, as fluid is moving forward, composition of fluid keep on changing depending upon what are the substances which are pulled back to the body and what are the substances which have been added. And as fluid in the end appears, of course on the way the substances which we need in our body, they are pulled back, and substances which we really don't need, they are secreted there. Is that right? But anyway, this tubular fluid, as it is passing through different segments of the nephron, they are being processed. And as they are being processed, what really happens that they appear in the end as a drop of fluid, and this drop of fluid is called urine. Now my question is very, very simple. I'm saying that every minute, how much fluid is represented to your nephron? Approximately 120 ml. Right? Out of this 120 ml, some is reabsorbed and some is added. In the end, what really appears here is urine. Every minute, out of 120 ml, please attention, every minute, out of 120 ml, how much appear in normal person as urine? Question goes to this young lady. Yes. Every minute, how much fluid appears as urine at the end of the nephron? I have told you what we have put in the beginning of the nephron is approximately 120, maybe few ml more will be secreted. So approximately we can say in whole your nephron system, every minute we put 120 ml. Is that right? In the end, urine appears. So we put 120 ml in a healthy persons, and what we get at the end after the whole processing of the fluid, how many ml fluid per minute?
Would be roughly the same.
It will be roughly the same, or will it be different? You have to be clever. Yes, madam is coming up with the answer. You just keep silent, all of you, yes. How much fluid will be coming here per minute? It's a very fundamental question, isn't it? That a good student know, this is a tube. We put 120 ml here on the head of the nephron. From the tail of the nephron, every minute, how much fluid is coming out? Yes, please.
120 ml.
Okay, now let's see. For a while we just trust she is right. Of course, I will tell you why she is not right. But listen, she says a very dangerous statement. She says every minute 120 ml is coming as urine. Is that right? Now, let's calculate how much urine she will be passing per day. Look, every minute, in 1 hour, how many minutes are there?
60.
Okay, she knows good, confidently that every hour is 60 minutes. And in 1 day, how many hours? Yeah? 24. And kidney work intermittently or continuously, healthy kidney? Yeah? Continuously. Now look at it. She has 60 minutes per hour and she has 24 hours to produce the urine. So how many minutes she has total? Of course, 16 to 24, it will become something like this. So, these are the number of minutes per day. Is that right? Now, according to her calculation, how much urine she is producing, let's look at this situation. She has 120 ml urine. She claims that every minute she is producing how much urine? 120 ml. So, 1 day, 1440. Now, let's see how much is the urine. Oh my God. Okay, yeah?
160 liters.
You have missed, how many liters? Okay, make it 100 so that we can make it easy. Attention please, let's make it easy. Okay, it's not 120 ml, it is 100 ml. 100 ml, so what it will be? 1440, if these are mLs per day. So per day, how much will be your liters of urine? About 144 liters per day. Oh my God, your own weight is not that much. It's a very dangerous statement she has passed. I don't know how she can produce more than 100 liters of urine per day.
I'll change the statement.
Okay, she will change the statement. Are you sure you don't produce that much urine? Okay, now you tell me, what is your latest assessment of your urine out?
1 ml urine
Only 1 ml urine
per minute.
per minute. Okay, now you see, this is called personality which only moves at the ends. About 10 minutes back, she was saying every minute she is passing how much urine? She is making how much urine? 120 ml. Suddenly, I don't know, somehow she decided it's too much, and now she end up with output per day. Every doctor must know that what is the normal urine output per day, right? Actually, it will be better, urine output keep on increasing and decreasing, right? We should say what is the abnormal urine output. If we define the abnormal urine output, then we can understand it between the two abnormal extremes, there must be normal urine output. The minimum urine output which a normal person should have is about 500 ml per day. This is the minimum. And maximum, you may have any amount, but still, we say when urine output is less than 500 ml, we say there is oliguria. Some people cut off at 400 ml. But anyway, what is oliguria? Oliguria is when your urine output in 24 hours is less than 400 or 500 ml. And polyuria is when your urine output is polyuria. Yes, polyuria means excessive amount of urine, right? That is more than 3500 ml per day. So again, anyone who produces urine less than half liter per day should be considered oliguric, and anyone who produces urine more than 3.5 liters per day, he should be considered polyuric. And it means anyone who's producing urine output somewhere in between should be considered normal. On average, normal person produces about 1.5 liters per day, 1.5 liter. Of course, this amount varies according to the environmental temperature and according to the input of the fluids and many other factors. But But we can say, let's suppose an average person is producing 1.5 liter of urine per day. When we say that average person is producing approximately 1.5 liter urine per day, it means normal person is producing how much urine? 1500 ml per day. Now let's go to our previous calculation. In one day, how many minutes you have? You never counted it. Of course. In one day, how many minutes you have? 16 to 24 is 14? 40. And if hypothetically, if I say that you are producing 1 ml urine per minute, it means 1414 to 1 ml is equal to 1440 ml per day. So we can say that every minute, if we are getting 1 drop of 1 ml urine here at the end of the nephrons, then it means in 1440 minutes of per day, you are producing this much urine. And this is very much near to what we have guesstimated or estimated the volume. So what did we learn here? A very, very important thing. What we really learned here is that your nephrons are master processor. When they're processing the filtered and secreted substances and reabsorbing them, they're processing in a great way. What they are doing. Out of 120 ml fluid which enters here into nephrons every minute, only 1 ml appears as urine. And somehow, when every minute 120 ml is passing along the tube of the nephron, all the things which are required by the body are pulled back. And only the waste materials are left behind, and some waste are also secreted. And eventually, out of processing of 120 ml of the filtered material every minute, this master chemist, make 1 ml urine. And during this process, it keeps your fluid balance, electrolyte balance, acid-base balance within normal range. This master processing machine, if there's more acid in the body, it will make the urine acidic. If there's more alkali in the body, it will make the urine alkaline. If there's excessive sodium in the body, it will bring more sodium out. If there's excessive potassium in the body and it's functioning normally, it will bring extra potassium out. If there's less sodium in the body, it will save the sodium in the body and bring less. So what I'm saying, nephrons are the master chemical processors. They chemically process all the filtered material, right? And out of 120 ml every minute, which they receive as filtered material, they end up with only 1 drop of urine every minute. This 1 drop is approximately how many ml? Just 1 ml. And in that 1 ml, whatever the waste product body has produced every minute, that is appearing. Is that clear? So in a very simple way, we can say, if for our convenience calculations, if we say there is a person who has approximately 100 ml filtrate, again it is also within normal range, healthy. If there is a person that every minute his nephrons are receiving how much fluid? 100 ml. Out of this 100 ml, when it is passing along the way, how much you receive here? Just 1 ml. It means how much is really taken back to the body? 99 ml. It means that on average, usually out of whatever glomerular filtrate is there, plus secreted material is there, 99% is reabsorbed, and approximately 1 ml is appearing as, or 1% of the fluid with the waste product is appearing into urine. Now listen carefully. If we give a drug which has the capability to convert 1 ml output per minute into 5 ml, it will be very powerful diuretic. Because urine output will be 5 times. From 1.5 liter it will go to 7.5 liter. And if there's a, so what I'm talking about, what diuretics have to do? Diuretics or natriuretic drugs have to play with nephrons and play only a little. Normally what nephrons are doing? Out of tubular fluid, 99% is reabsorbed, only 1% is appearing as urine. Right? And if along the nephron, there are points which I will explain into detail, the different areas which are reabsorbing salt and water, sodium absorption or water absorption in different ways. And if drugs interfere with different segments of the nephron in such a way that sodium reabsorption or water reabsorption is reduced, there will be excessive output of urine, and we say that if sodium is becoming primarily excessive, we say there's natriuresis. And as I told you that whenever sodium is appearing excessive there, it will bring along with it extra water, and if sodium is bringing extra water along with it, it means natriuresis is also, the substance which was natriuretic is also diuretic, right? So the next logical step in our lecture must be that we must understand. What should we understand? We must understand what are the normal mechanisms along the tube to reabsorb the sodium. For example, proximal convoluted tubule reabsorb the sodium in a different way. Thick limb of ascending part of loop of Henle reabsorb sodium in a different way. It is a different mechanism. This part, which is distal convoluted tubule, it reabsorbs the sodium by different mechanisms. And in the end, your collecting tubule reabsorbs the sodium in a different way. So different drugs interfere with the reabsorption of sodium at different parts of the nephrons, so that less sodium is reabsorbed and more sodium appears as urinary sodium and producing the natriuresis and diuresis. So to understand natriuretic drugs, diuretic drug, first we should understand that what are the normal mechanisms along the nephron, normal mechanism of sodium reabsorption. And then we should see how diuretic drug interfere with those mechanisms, right? We'll be talking about that. How different parts of nephrons handle the sodium. And then logically we will go to how different diuretic or natriuretic drugs interfere with reabsorption of sodium and water. Look here. How many areas are present there on which sodium handling we have to consider? Let's suppose here's a typical nephron. And first of all, I will talk about this particular cell. The cells in this area, let's suppose I will draw this cell into detail, and I'll tell you how this cell is handling the sodium and water. I mean, what is the role of proximal convoluted tubule, right? This should be our first step, role of proximal convoluted tubule. Then the second important point will come, the thick part of ascending limb of loop of Henle. How it is handling with the sodium. This will be our second segment of information, quantum of information. Next quantum of information should be how the distal convoluted tubule is handling the sodium. And in the end, we shall talk about how the collecting tubular cells, right? Collecting tubular cells are handling with the sodium. So at first, I will go into detail of this one, right? Now, let's make one big nephron and see how it is processing water and sodium. This is proximal convoluted tubule, and here it is a cell, proximal convoluted tubular cell. I've just represented here one cell, but actually there are thousands and thousands of cells on all the sides of proximal convoluted tubule, right? And what is here? Yes, please.
Descending limb of
Henle. Then we'll talk about thick part of ascending limb of loop of Henle. And this is collecting tubule. First of all, we have to see how this cell, which is representing which function of proximal convoluted tubule, how it it is working as far as sodium and water is concerned. In second part, we'll talk about this cell. What is this cell? Cell of thick ascending limb of loop of Henle. This will be our second discussion. Third discussion will be how this part, what is this cell, what is this? Distal convoluted tubule. And in the end, we'll see how this particular cell is handling with, that is collection tubule. Now, let's talk one by one, step by step. First of all, this cell. When fluid is passing nearby, how it handles with the sodium and water. Okay, here is your vascular system, afferent arteriole, here is glomerular tuft, efferent arteriole, and this is peritubular capillary network. Right? We were talking previously, from here the filtrate was appearing. Let's suppose here filtrate is 100 ml per minute. Glomerular filtration rate, in this particular case, usually it is approximately 120 ml per minute. Now, when this filtered fluid is passing through the proximal convoluted tubule, what really happens to this fluid? Listen carefully. On the luminal side, the cell has two sides. One side is facing to the lumen. We call it, luminal side of the epithelial cell. And then, this is the other side of the epithelial cell, and this side is called basolateral side. This side of this proximal convoluted tubular cell is called basolateral side. Actually, what really happens, there must be one cell here also. There should be one more cell here also. I've just enlarged one cell. Actually, there are special proteins which are holding the cell together like this and like this. These proteins which are holding the cells like this, they are acting as a very special type of junctions. Special stitching, you can say, unit. And whatever transporter proteins, cells are made of lipid bilayer. This is the luminal face of the cell, and this is the basolateral side of the cell. And cells are attached with each other with proteins on the sides. Now what really happens? There are different proteins which are present on the luminal side, which are supposed to handle the, listen carefully. There are some proteins which are present on this side. And there are other proteins which are present on this side. Now, it means these proteins cannot come to the basolateral side. The proteins, the transporters or channels which are present on the luminal side, they cannot float to basolateral side. And the proteins and, you can say, different transporters or channels, or you can say these which are planted by the nature on basolateral side, they cannot come to the luminal side. So we have a very basic concept right now. The luminal side of the nephron cells and the basolateral sides of the nephron cells are having different functions. Why? Because proteins which are expressed on the luminal face of the cell are very different. The transporters, channels, or other proteins which are presented or embedded or operative on the luminal side of the nephron cell are very different than the proteins or different channels or transporters or enzymes which are present on basolateral side. Due to this reason, we say luminal side has different specialized performance and basolateral side has different specialized performance. This is the first thing which we should know, that nephrons are made of epithelial cells. Epithelial cells have luminal faces and they are having basolateral sides. Luminal sides are having different type of functions, and basolateral sides of these cells are having different type of functions. Now let's suppose, what are different functions present over here? Okay, let me tell you. One of the very important thing which proximal convoluted tubule has to do is that it has to reabsorb the sodium. Lot of sodium is filtered here, and out of the sodium must go into cell. It means it has to cross the barrier of luminal membrane, because sodium is a charged molecule. It cannot simply dissolve into lipid. So it cannot go by simple diffusion. So it has to be somehow transported in a special way from the luminal side to the intracellular fluid, and from the intracellular fluid this sodium has to go out of the cell by another specialized mechanism. So there should be some special mechanism on luminal side. There should be another special mechanism on basolateral side. And then in this way, filtered sodium should become intracellular sodium, should be transported by the basolateral side to the interstitial fluid, and from the interstitial fluid, it should go back to the blood. So what is really happening with the sodium? The sodium is coming from the blood, becoming the part of the tubular fluid. The luminal cells should take up sodium by some special mechanisms, and this filtered sodium or tubular sodium should become intracellular sodium, right? And then there should be some specialized mechanism on basolateral membrane. We should take the sodium from the cell to the interstitial fluid, and from there the sodium should go back to the body, right? Now another thing, sodium is very important to be taken back to the body, but along with sodium, many substances are reabsorbed in the proximal convoluted tubule. Along with sodium, many other important substances are reabsorbed in this area, right? I will not go into detail of that physiology, but first of all, I will talk about how sodium reabsorption is coupled with bicarb reabsorption. You know, it's not the only sodium which filters. Sodium filters along bicarb and sodium filters along chloride. It means sodium bicarb filter, sodium chloride filters. So it means sodium has to go back, bicarbonate has to go back to the body, and even chloride has to go back to the body. Now, first of all, sodium reabsorption I will discuss in reference to bicarbonate reabsorption. That when sodium is reabsorbed, along with that, what is reabsorbed? Yes, please? Bicarbonate. Because it is very important. Bicarb is your very important alkali in the blood. And this alkali freely filters. Bicarb freely filters into filtrate. And we cannot afford to lose all the alkali into urine. Why? Because our cells are all the time producing acid. You know, cells produce carbon dioxide and which react with water and become carbonic acid. That is acid. Our cells during the metabolism are machines. Our cells are such biological units which are constantly producing different type of acids. And to keep the acid-base balance, not only we should get rid of the acids out of the body, it's another very important concept that we must retain our alkali. Otherwise our acid-base balance will be very much disturbed. So, in the proximal convoluted tubule, sodium is reabsorbed in many different ways. One of the ways that reabsorption of sodium is associated with reabsorption of alkali or bicarbonate. Let's go into detail how it really happens. Actually, there's a very special type of transporter here, right? On which side? What phase is this one? Luminal phase, right? Let me make it that this is the luminal phase. On the luminal phase, there's a very special type of transporter protein. And this protein, right, it behaves in a very important way that it can take the sodium from here in. And whenever it takes some sodium here in, it throws one proton out. So what is the function of this protein? It is constantly taking the sodium in, and whenever it takes one sodium in, it will secrete one proton into proximal convoluted tubule, right? It means along the luminal membrane, what it is doing in transporting the sodium and proton into different directions. So we call this protein sodium proton counter transporters. We call these proteins sodium protons counter transporters. But before I really go into further detail, I just remember to introduce you to a very basic concept about the basolateral membrane, right? Then we'll come back to this information. Actually, you see that sodium is very important substance present in filter, and from different part of the nephron it should be reabsorbed. It means that different cells in the nephron should be normally rich in sodium or poor in sodium. cells should be poor in sodium so that they can suck the sodium, they can pull the sodium, they can take the sodium from the luminal side to intracellular side. So all the nephron cells are poor in sodium. But why they are poor in sodium? Why they kept poor in sodium? Right? Let me explain what is the mechanism. Actually, there is a very, very special enzyme here, or rather not enzyme, I must say a transporter. This is sodium potassium transporter. Such molecules are present only on the basal. These molecules are present only on the basolateral membranes. What these molecules are doing? These molecules are constantly eating up ATP. They are energized by ATP. And whenever they utilize one molecule of ATP, right, they get energized. Every time they throw 3 sodiums out. They capture 3 sodium from intracellular fluid and throw it out. And they capture 2 potassium from the interstitial fluid and throw into cell. So this is what they are doing. They are transporting sodium. And because they are utilizing energy directly, we call them primary transport mechanism of sodium and potassium. And because they are throwing the sodium out and throwing the potassium into cell on the basolateral membrane, right, by the utility of ATP, we simply call them sodium potassium ATPases. These enzymes are called, or transporters are called, sodium potassium ATPases. Now, these sodium potassium ATPases are planted on all the basolateral membranes of the nephron cells. Look, this is sodium potassium ATPase, isn't it? It is present on which wall? Yeah, basolateral. In the same way, here are also sodium potassium ATPases. Again, they are present only on basolateral membrane. But can they float to the luminal side? Answer is no. Again, this cell also has sodium potassium ATPases, and they are present on which side? Basolateral membrane. Even the cells which are present over here, they are also having sodium potassium ATPases, and they are again present on basolateral membrane. From today onward, you must remember what you should remember. You should remember many things, and one of that is that basolateral membranes of the nephron cells are loaded and decorated with what? Sodium potassium ATPases, and they are constantly throwing the sodium out of the cell and bringing the potassium into cells. It means we can say the nephron cells are rich in potassium and nephron cells are poor in sodium. Now we can come to a very basic understanding that if all the nephron cells are poor in sodium, it means they will love to have sodium from luminal side to the intracellular side. They will love to suck the sodium. They will love to pick the sodium from the luminal side to the cell, because the nephron cells are poor in sodium. Why they are poor in sodium? Because sodium potassium ATPases are constantly performing on the basolateral membrane, and they are throwing the sodium out of the cell. So cells become poor in sodium. So they have a high tendency to take up the sodium from the luminal side to the cellular side. But the question is there that sodium is a polar substance. It cannot dissolve into luminal lipids. So it cannot, by simple diffusion, go into these cells. So different cells have different mechanisms. They have evolved different mechanisms on their luminal side to take up the sodium from the tubular fluid to intracellular fluid. Right? Now, there's so many mechanisms which are operating in different parts of the nephron. I'm talking about one of those mechanisms which operates in proximal convoluted tubule. Let's come back. As I told you, sodium potassium ATPases are constantly operating on the basolateral membrane, and they're throwing the sodium out. So this cell becomes poor in sodium. So sodium will love to come into it. But how sodium comes into it? By help of special transporters or by help of special channels. Here what we are concentrating on a very special transporter which can transport sodium from the luminal side to the cellular side, and during this it will always exchange one proton from, or hydrogen from the intracellular side to the luminal side. Is that right? So this molecule is called sodium proton counter transporters. Is that right? Now, when sodium comes in, it is throwing the proton out. Now what happens to this proton? This proton fuses with bicarbonate. This proton fuses with this filtered bicarbonate. When bicarbonate fuses with this proton, both of them react with each other, they convert into a compound which is called H2CO3. What is it? Carbonic acid. It means in the lumen of proximal convoluted tubule, secreted protons are constantly reacted with filtered alkali. Secreted protons are constantly reacting with filtered alkali, bicarb, and they are constantly generating what? Carbonic acid. And then there is a very important enzyme here. Right? Expressed on the luminal membrane. And this enzyme breaks down this particular substance. What is this substance? This enzyme will work on carbonic acid and break down the carbonic acid into water and carbon dioxide. What should be the name of this enzyme? Yeah, carbonic anhydrase. The name of this enzyme should be carbonic anhydrase. And because it is applied on the luminal side, so this carbonic anhydrase is called luminal carbonic anhydrase. So what did we learn after this? That secreted protons and filtered bicarb react with each other in the luminal fluid and make, yes, they make carbonic acid, and then luminal carbonic anhydrase help it to break down to carbon dioxide and water. And carbon dioxide concentration progressively become more in the luminal side. Of course, this will move from high concentration to low concentration, as we say, and carbon dioxide is lipid soluble, so it will very easily slip into cell. So cell will be receiving carbon dioxide from the luminal side. Plus, cells also produce carbon dioxide themselves also. So carbon dioxide is present into this area. Now this carbon dioxide will react with intracellular water. Cells have a lot of water. Even cells can generate water. When they break down the glucose, the fatty acids and other. Anyway, so when carbon dioxide is coming here and intracellular water react with carbon dioxide, then both of them are going into H2CO3, carbonic acid. Again, enzyme which is working here is cytoplasmic or intracellular. What is that? Carbonic anhydrase. Now we see there are two carbonic anhydrases. One variety is decorated on the luminal side, other variety is present in the cytoplasm. So cytosol. So cytosolic carbonic anhydrase help the carbon dioxide and water to fuse into carbonic acid, which breaks down. This carbonic acid break down into proton and what is this? Bicarb. What is this? Bicarb. And this bicarb will go out through a special exchanger which is exchanging the bicarb with chloride. And this bicarb will reach now to interstitial area, and from here when its concentration become high, it will go back to the blood. So what we have done? Meanwhile, the sodium which was taken in by this transporter, that was also by sodium potassium ATPase will go to the interstitial fluid and eventually to the blood. So what did we learn? We learned one thing, that here this mechanism, what it was doing, it has reabsorbed sodium along with the bicarb, but in a very indirect way, right? Now let me put a question to you. Let's suppose if we have a drug or diuretic which can specially disturb this enzyme. We have a drug and this drug can disturb this enzyme. What is this? Carbonic anhydrase. This is the black drug, and this black drug is able to react with carbonic anhydrase and make its function lost. What will happen really? What really happens that carbon dioxide cannot be generated here, or carbon dioxide and water within the cell, can it be fused or not? So when intracellular carbonic anhydrase is reacting with a drug and this drug will not allow the enzyme to work, then intracellular carbon dioxide and water cannot fuse. It means cell cannot generate its own carbonic acid. It means cell cannot generate its protons. It means cell cannot throw the proton out. If cell cannot throw the proton into luminal fluid, it means if protons are not going out, then this exchanger is not going to work. So some amount of the sodium which was supposed to reabsorb through this pathway, that will not be reabsorbed. So we applied the drug on these 2 points. We did not allow, so this cell failed to secrete protons. So proton exchange, sodium is not reabsorbed. So you can say some sodium which was supposed to be reabsorbed here, it may eventually appear into urine. So this will produce some degree of natriuresis. But with this natriuresis, the urine which is coming here, with natriuresis, there will be one more problem. What will be the problem? That whatever bicarb is coming here, does this bicarb have proton to react? No. And even if somehow it reacts, can it go through all this process? No. So what will happen? Number one, some sodium is not being reabsorbed. Number two, that some bicarb, rather a lot of bicarb, is deprived of the protons, and when they are not receiving the protons, these bicarb remain bicarb. They don't go into carbon dioxide. Number one, protons are not there. Number two, this enzyme is not working. So what really happens? Do you think now proximal convoluted tubule will reabsorb the bicarb? No. So bicarb will filter down or track down into what? Into this bicarb will go down. And major site where bicarb is reabsorbed is proximal convoluted tubule. If a lot of bicarb from here is spilling into distal part of the tubular fluid, there is no very effective way to reabsorb such a heavy amount of bicarb. So this bicarb will also appear into urine. So this person will have not only natriuresis, but he will have bicarbonate urea as well. Right? It means this person will have some natriuresis, with that some bicarbonate urea, and of course when sodium and bicarb are going over there, they will pull some water with it, and of course there will be what? Diuresis. And there will be what? Diuresis. So there will be natriuresis, there will be bicarbonate uresis, there will be diuresis. And another important thing, this type of drug will make the urine acidic or alkaline? Alkaline. And of course, when you are losing bicarbonate to urine, so your body is deprived of the bicarb, so body will become acidic. So it will produce this type of drug. Number one, it will produce natriuresis. But remember, the sodium which is not reabsorbed here, it may be reabsorbed from some of the sodium which is not reabsorbed here. Out of that sodium which is inappropriately pushed to the distal part of nephron, some of it will be reabsorbed from distal part of the nephron. So natriuresis will be mild or heavy? Mild. Even though the amount of sodium which did not reabsorb here, right, it will be going to the distal part of the nephron, but in distal part of the nephron there are more mechanisms to reabsorb sodium. So out of the sodium which was not reabsorbed here, some sodium will be still reabsorbed, so extra sodium will appear into urine, but in a small amount. So it is a mild natriuretic. So it will be also mild diuretic. Is that right? And this diuretic will produce bicarbonate urea with it. It will produce the urine which is not only having more sodium, it will produce the urine which is not only have excessive bicarb, but this urine will also have extra water. Am I clear to everyone? Is that right? Now, and it will make the urine alkaline, and of course body will become acidic. The drug which is working at this particular point, this drug is called, yes, acetazolamide. What is carbonic anhydrase inhibitors, and this drug is basically, this drug is, what is the name of this drug? Yeah, it is classically acetazolamide. So here we can say acetazolamide primarily work on the proximal convoluted tubule. It work on the luminal and intracellular carbonic anhydrases. When carbonic anhydrases are not working, cell is not providing the protons to be secreted, so in exchange of those protons, sodium cannot, because sodium protons are not there to be exchanged, so sodium proton exchanger does not work, counter transport does not work, so sodium is not absorbed to some extent here, right? So this sodium will go into distal part of nephron, a part of it will be reabsorbed, part of it will appear as extra sodium into urine, which will produce a mild degree of natriuresis. Another phenomenon along with that will be that when protons are not secreted, then filtered bicarb cannot react with that, and bicarb remain as such, and distal part of the nephron cannot reabsorb so much bicarb, so heavy amount of bicarb will appear. When heavy amount of the bicarb will appear there, then there will be not only natriuresis, there will be bicarbonate also, and person's urine after acetazolamide administration will become alkaline, and of course with the time body is losing its alkali, so person's blood will become acidic. Am I clear? There are some very interesting phenomena in last part of the nephron here, right? That this part of the nephron is supposed to secrete the potassium, right? And there are special channels in collecting tubular cells, and these are called potassium channels. Again, in these cells, what is happening? Listen carefully. What is happening to these cells, collecting tubular cells, especially principal cells, the special type of cells which are called principal cells? Now, they are operated by aldosterone, right? Normally, how these cells are working, let me tell you how these cells are working. There's the blood. Now, these cells are having on basolateral side which thing? Sodium, potassium, ATPases. They are having sodium, potassium, ATPases. And on the luminal sides, these are having sodium. Yeah, what are these? These are sodium. Don't tell me transporters. These are sodium channels. These are sodium channels. Now look, on this cell, on the luminal side, it is having potassium and sodium channels. And on basolateral side, it has sodium, potassium, ATPases like other cells. Now, these cells are constantly taking the sodium from basolateral side and pushing into cell. Okay, I'm wrong. Let me correct myself. Sodium, potassium, ATPases from basolateral membrane, they are constantly throwing the sodium out of cells. You know, 3 sodium goes out. And they are constantly bringing what in? Potassium in. So it means that these cells, like other nephron cells, are constantly throwing the sodium out, so they become sodium poor, and constantly from basolateral membrane, due to sodium potassium ATPases, they are accumulating the potassium, so they become potassium rich. Now listen one thing. They are having both sodium channels as well as calcium channels. Due to this reason, whatever sodium is present here, this will love to go in so that it can go back to the body. Is that right? And whatever potassium is here, because cell become very rich on potassium and its luminal membrane has channels for potassium, so this potassium will come, yes, into lumen. It means these cells, collecting tubular cells, on the luminal side have capability to reabsorb sodium and capability to secrete potassium. Is that right? Another thing which you really know is that sodium reabsorption is more than potassium leakage. When sodium is constantly moving in, then luminal side of the membrane will become electropositive or electronegative. It should become electronegative. So we can say luminal fluid or luminal side of the last part of the nephron is electronegative, because from here sodium is rapidly going in and usually less amount of potassium is coming here. So, and secondly, sodium is going in but chloride is not going along with it. So naturally anions are left behind but cations are going in. And whatever cations are going in like sodium, some cations like potassium are coming into lumen. But the number of cations which go into cell are more than the number of cations which are coming from the cell. Due to this reason, we can say that luminal side is losing more cations to the cell and gaining less cations from the cell. Number 2, luminal cell is not taking up the anions. Due to this reason, normally this luminal side is electronegative. Am I clear to everyone? Now, I will tell you something very important. We keep on hearing that there are some diuretics We keep on hearing and discussing and reading that some diuretic waste the potassium and other diuretics spare the potassium. Let's clear this concept forever. That why one group of diuretic are potassium wasters. We call them potassium wasters. And why some group of diuretics are potassium sparing. Let's discuss it. Let's come to the very first drug, acetazolamide, which we were discussing. The acetazolamide was working on this side. It was increasing the load of sodium to distal part. It was increasing the load of bicarb to distal part. It was increasing the load of water to this part. Is that right? So we can say when drug is working here, acetazolamide is working here. So what is really going more distally? Extra load of sodium, more than the normal. Extra load of, yes, bicarb, right? And extra load of water. You are so intelligent. I was explaining that when you give a person acetazolamide, right? This will react with carbonic anhydrase on the luminal and carbonic anhydrase in the cytosolic area, and it will reduce the sodium reabsorption from proximal convoluted tubule, and it will reduce the bicarb reabsorption from proximal convoluted tubule. What will be the result? The sodium and bicarb load will move forward in distal part of the nephron. Some of the sodium will be reabsorbed from distal part of the nephron, but still some extra sodium will come into collecting tubule. Along with the sodium, a lot of bicarbonate will come. And of course, the sodium and bicarb, they will osmotically pull water with them. So we can say what acetazolamide has done. Acetazolamide has increased the sodium load in last part of nephron. It has increased the anion load, and it has increased the water load. Now these three things will increase the potassium wasting. But how? Cause number one. The extra sodium which come here, some of the sodium will be taken by these cells. If these cells are getting extra sodium, now listen, any diuretic which work proximal to this point and it brings more sodium here, it means these cells are able to take up more sodium. It means they will be pumping out more sodium to basolateral side, to the blood. It means that these sodium potassium ATPases will be bringing in more potassium. So intracellular potassium level will go high. So potassium concentration gradient from the cell to the luminal fluid is now getting higher. So more and more sodium arrives here. More chances the sodium will be taken up by these cells. More their basolateral sodium potassium ATPases will work. Of course, this extra sodium will be reabsorbed, but a lot of potassium will be taken in, and cells become more rich in potassium. And cells, these are principal cells in the collecting tubules. When they become really extra rich in potassium, right, what really happens, that movement of potassium under the concentration gradient from the cell to the lumen will be normal or more than normal? More than normal. So number one, these cells will be secreting extra potassium, so this will lead to excessive loss of potassium. We call it kaliuresis. We call it kaliuresis, excessive loss of potassium. This is mechanism number one. Mechanism number two is these anions, bicarbonates. If any diuretic, please listen carefully, any diuretic which work proximal to this point and increases anion load in this area. Anion may be bicarbonate or it may be chloride. In this particular example, it is bicarbonate. If bicarb load in this area is increased, it means when bicarb are going down, they will attract cations from the cells. Because when extra bicarb come over here or extra anion come over here, the lumen will become more electronegative. And when lumen will become more electronegative, it's very natural that cations from within the cell will jump out. And which cations are jumping out? From the cell into lumen? Potassium. So whenever any diuretic which work proximal to this point and load more and more anion to this area, in this particular acetazolamide example, bicarbonate is being loaded in this area, but in some other diuretic we'll talk about later, the chloride is loaded in this area. So bicarb or chloride, whatever anion is overloaded in this area, this makes the membrane luminal side extra electronegative. When this area becomes too much electronegative, what really happens? What really happens when it becomes too much electronegative? The result will be that this electronegativity in the lumen will attract more potassium from the cell to this, and this is the second reason that potassium loss will be increased. Third reason is very simple but very important. Any diuretic which is working proximal to this point, that will increase water load also in this area. And if water load in this area increases, it means if there is more water reaching here, more than normal amount of water which is reaching here, it means flow here will be slow or fast. Luminal flow
Will be fast.
fast. Look, all the diuretic which work proximal to this, they bring more sodium here. Some of them bring more
Bicarb.
anions here, and of course they also bring more water here. And when more water is coming on the last part of the collecting tubule, in the collecting tubule rather, what really happens? When more water is coming here, the luminal flow will become slow or fast? It will become fast. And when luminal flow will become fast, it means potassium will be washed away gradually or rapidly. And if potassium is washed away from this side towards the last part of nephron very rapidly, then potassium concentration in the lumen becomes very low. So concentration gradient for the potassium from the cell to the lumen will become again very high, and excessive potassium will be lost from the cell to the lumen. So it means that further kaliuresis. Now let me recap what I was saying. I was trying to give you a very important concept, that all the diuretics, listen carefully, all the diuretics which work proximal to the collecting tubules, and they are bringing more sodium into this area, or they are bringing more anion to this area, or they are bringing more water to this area, they are going to lead to heavy potassium losses from the body, right? Again, if more sodium is coming here, the sodium will be exchanged for the potassium. If anions are coming here more, they will attract the potassium which is cationic into lumen. Or if more water is coming here, then potassium concentration in this area will drop as potassium is being washed away, and more potassium from the cell will spill into tubular fluid. So as a rule, we can say the diuretics which work proximal to this point on the nephron, all of those diuretics are potassium wasters. All of them are potassium wasters. And how the potassium sparing drugs work, we'll talk later in the lecture. Now we'll be talking about basically that how this thick ascending part of the loop of Henle handles the sodium and different anions and water, and how the drugs or diuretics work on this part and alter the fluid electrolyte balance in the blood as well as in the urine. But before we really concentrate on that, I want to highlight a very important point. The very important point which I want to highlight before really I go into detail is that some part of the nephrons are freely permeable and to water and others are not. Let's look at whole diagram and we'll see it that this is which part of the nephron? Proximal convoluted tubule and descending loop of Henle. This is proximal convoluted tubule, and here it is descending loop of Henle DLH, right? And here is hairpin turn, and then this is thin part of ascending loop of Henle, and this is thick part of ascending limb of loop of Henle. Now the point which I want to highlight, that first of all, as good doctors, you must be very clear that which part of the nephron has what type of permeability to the water. Now, this young lady is going to tell us that water permeability in this part, yes, water permeability to this part is regulated by which substance? Yes, please. Yes. You have to tell me that which substance regulates the water permeability along this proximal convoluted tubule and descending loop of Henle. Yes, please. Do you know any substance or any factor which alters the water permeability? You should not know, because no one knows. The point which I want you to remember is that this part of the nephron is, under all circumstances, freely permeable to water. Remember, even though in the books we read that there are tight junctions in between the cells, they are tightly holding the cell together, but they are water leaky. So we can say this part of the nephron is always leaky to water, or always freely permeable to water. What is its implication? What's the fun in knowing this point? The fun in knowing this point is that when water comes here, when filtrate comes here, right, its osmolality is the same as blood. Blood has a osmolality of about 280, or you can say 300 milliosmol per liter. Milliosmol per liter. When filtrate comes here, again it has osmolality of 300 milliosmoles per liter. As fluid is going down, you know there's uptake of all the glucose from this area is reabsorbed. All the amino acids are reabsorbed by proximal convoluted tubule. About 65% of the sodium is reabsorbed. Some sodium here is reabsorbed as a counter transport with protons. Some sodium is reabsorbed with glucose. Some sodium is reabsorbed along with chloride. Some sodium is reabsorbed with bicarb. Some sodium is reabsorbed with phosphates. Some sodium is reabsorbed with amino acids. So what really happens? That as water is going down, lot of solutes are being reabsorbed. So a lot of solutes are moving from luminal side to the intracellular side to the pericellular area or outside the cell. If a lot of solutes are moving like this from the lumen to the cell, from the cell to interstitial fluid to the capillary, if solutes are being pumped or transported in this direction, and if this part of the nephron is very, very permeable to water, then water will follow. You know, solutes drag the water. So what really happens? When solutes are moving, water is moving with the same ratio. And by the time the fluid, for example, here it was 100 ml fluid, by the time fluid reaches here, it is left only 35 ml per minute. Is that right? So it means about 65% of solutes and water are reabsorbed. And do you think what will happen to water? By the time water from here to here it reaches, or luminal, you can say fluid as it is going down, and it is exiting from the proximal convoluted tubular system and entering into loop of Henle, then its osmolality, which was at entry point 300 milliosmol, what will happen to its osmolality? It will get this fluid as it is going down, it will get diluted or it will get concentrated. Yeah, it is going to get concentrated. Again, young lady, there is a question. Let's suppose you make some juice, is that right? And out of that juice, you have 3 glasses of juice in a jug, you remove the 2 glasses of juice, what will happen to the rest of the juice? It get concentrated or diluted? It will be the same. Same thing happen here. This is what I'm trying to tell, that from here solutes are going along with the water. Water is allowed to freely follow the solute. This part of the nephron is always permeable to water. That is why water always follows it. So as solutes are moving, it should get actually diluted. If from a material, if you are removing the, from a, you can say solution, if you are removing the solutes, the remaining solution should become diluted. But if along the solute, solvent is also following, and both are following in the same ratio, do you think they will get concentrated or diluted? Not at all. So what really happens, amount of fluid here and amount of fluid here is very different. But osmolality of fluid here and here is the same. And we say absorption of the solutes and water from the proximal convoluted tubule is isotonic, because on the way fluid does not become hypertonic and does not become hypertonic. Am I clear? Now, let me tell you a very simple thing. This part of the nephron, proximal convoluted tubule until, what is this? Descending part. Up to this point, nephron is freely permeable to water under all circumstances. Then we start going up. As it is going up, nephron become absolutely water impermeable, and under all circumstances it remains water impermeable. What does it mean? That if I draw a mini nephron here, okay, just for your understanding, here's a mini nephron. Look, this part is always allowing the water free movement, freely permeable to water movement, right? What is this part of the nephron? Proximal convoluted tubule and descending part of descending loop of Henle. And this part is always water impermeable, whatever you do. It means this part, descending part, will allow the solute to move and let the water to move with them, right? But this part will allow the solute to move but never allow the water to follow. It means in this part solute will move out, but water will never move out with that. It means as tubular fluid will go upward, it loses the solutes on both sides, but it does not lose water. So progressively it becomes diluted. So what we really say, that the fluid which enter here, its osmolality is 300 milliosmol. When it reaches, as it is coming down, it up to proximal convoluted tubule, it remain same. Isotonic absorption is there. But really what happens, look here, when fluid is going upward, right, solutes are thrown out, but water is not allowed to follow, because this part is permanently water sealed. It is the waterproof part of the nephron. It is the waterproof part of the nephron. So as luminal fluid goes at this point, it will be highly diluted. So we say this segment is a diluting segment. Am I clear? After this, when fluid will move forward, if there is no ADH, if there is no antidiuretic hormone, this part will always remain water impermeable. But if there is ADH, then this part of the nephron will become water permeable. It means, listen carefully, so it means when it is, look, when fluid is descending into nephron, right, in proximal convoluted tubule and which one? Descending limb of loop of Henle. When fluid is descending down, water can move along the solutes. Is that right? But as fluid start going up through ascending limb of loop of Henle and thick part, solutes are allowed to move out, but this is always water impermeable part. And last part of the nephron, its water permeability depends on the presence or absence of ADH. If ADH is not there, it remains water impermeable. And if ADH is there, then this area will become water permeable. Later on I will explain that as you move down in this diagram, osmolality keep on increasing. Osmolality from, this part is in the cortex and this is in medulla. In medulla there is hyper osmolality. In medulla, as you go down into medullary interstitium, from cortical side to medullary interstitium, osmolality increases, right? Now, it means that this tube, which is initial descending part, it moves from less osmotic interstitium to hyperosmotic interstitium to medulla. So when nephron moves from cortical area to interstitial part of medulla, then what happens? Interstitial fluid become progressively more and more, yes, concentrated. Interstitial fluid become more and more concentrated. And when this goes up from highly concentrated area, it is going to less concentrated interstitium. When it turns back again from less concentration, it is going to high concentration. Let me explain. Osmolality here, osmolality scale I am making. Osmolality in the cortical area is 300. As you come down, it becomes 600. You come further down, it becomes 900 milliosmol. Then it becomes 1200, and in some circumstances it becomes 1400 milliosmol per liter. It means as you move from cortex to medulla, interstitium is becoming more and more hyperosmolar. And as you move from here, what is this? From medulla to cortex, it becomes less and less osmolar. And again, in the last part, again when it dip into medulla, from the cortex to medulla, collecting system, again it is dipping into highly osmolar, what? Interstitium. Am I clear? Now listen, what's the importance of knowing this thing? I've explained two things. Number one, from cortex to medulla, interstitium become more and more, progressively more and more osmolar. Number one. Number two, another point which I want to, we have to concentrate on this part, please. Right? Now, another part which I want to concentrate, that this part of the nephron, proximal convoluted tubule and descending limb, it is freely permeable to water under all circumstances. Then ascending part is, and early part of distal convoluted tubule is always water impermeable. And last part is water permeable if there is ADH, and it is water impermeable if there is no ADH. Now let's make one more concept. What is that? Look, as fluid is coming down, right, we can make now diagram here. If here osmolality is 300, here it is suppose 600, here it become 900, it become 1200, and sometimes it become 1400. Now what we really see, that now let's come to the main diagram, and what we will see, we'll focus on the whole diagram. What we really see, that from the right fluid here was having fluid which is in the luminal area, it has the same osmolality which was outside interstitium. But as this reaches here, descending limb is going into what? Hyperosmolar area, hyperosmolar interstitium. So it means that osmolality or solutes are more outside and less inside. So this part of the nephron will lose water. Right? Now listen carefully. It will lose the water, but it will not lose much solutes. So what really happens? Compare early part of descending system and then late part. In proximal convoluted tubule, whatever solutes are absorbed, in the same ratio, water is absorbed. So within the lumen, osmolality remain same. But when we come to this part descending, the fluid which enters here, it has osmolality of 300. Right? And outside osmolality is getting more and more hyperosmolar. So it means that luminal fluid is become, as compared to the outer fluid, is far less osmolar. So what really happens? Water start going to from hypotonic area to hypertonic area. So water start moving out of descending limb of loop of Henle, and some solutes start jumping in. Right? So what really happens? What really happens? That by the time water is gradually, tubular fluid is gradually going down, tubular fluid is losing the water and gaining the solute, because its membrane is freely permeable to solutes and water. So by the time fluid come here, its concentration is also same as outside, because it has equilibrated. So it means that when fluid is going from Bowman capsule up to the end of proximal convoluted tubule, there is isotonic absorption of solutes in the fluid. But as it moves in the initial part of descending limb of the loop of Henle, because it is surrounded by hyperosmotic interstitium, so progressively it loses the water and progressively it gain the solutes. So by the time fluid reaches hairpin turn, it becomes hyperosmotic. But as soon as this fluid start going up, as soon as this hyperosmotic fluid from the which area? What is this area? Hairpin turn. As soon as this fluid start going up, the walls become water proof, impermeable. They become absolutely water impermeable. Because these walls become totally water impermeable, now fluid, highly concentrated fluid is going up. Is that right? Then what happens? I will explain. These cells throw actively solutes, but they don't allow the water to go to interstitium. So as fluid in the luminal area is going up, right, into thick part of ascending limb of loop of Henle, it is progressively losing solutes, but it's not losing water. So what really happens? These solutes which are constantly coming here, they will make this area hyperosmotic. They are responsible to make this area hyperosmotic, because this part of the nephron can throw solutes very actively out, right, into interstitium, but they don't allow the water to follow. And they are responsible to keep the medullary interstitium hyperosmotic. But by the time fluid reaches here, it has lost a lot of solutes out. So fluid will become hypotonic, or it will become diluted or concentrated. And once it becomes diluted, it may become only 60 milliosmoles. Now look, under all circumstances, this part of the nephron is water impermeable. Under all circumstances, right, under physiological circumstances, it is throwing constantly solutes out. So it means this part is responsible to dilute the luminal fluid, and this part is responsible to make hyperconcentration in interstitium, right? Some people refer this part of the nephron as diluting segment. They call it diluting segment. Now listen carefully. If you have diluted the urine, and if there is no ADH, and if there is no ADH, this part of the nephron will remain water impermeable, and diluted urine will keep on going forward without losing any water. So person will pass what type of urine? Highly diluted urine. But let's suppose if your ADH level is high and you don't want to lose the water, then ADH hormone will alter these cells. And ADH hormone will alter these cells will become water permeable. And once these cells become highly water permeable, then from here highly diluted fluid is going down. Is that right? But as highly diluted fluid is going down, if this area was impermeable, right, even though this part of the nephron is progressively going to medullary interstitium and dipping into more and more hyperconcentrated interstitium, but if there was no ADH and it is highly impermeable, then diluted fluid will be passed out as diluted urine. But if this part become highly permeable to water due to presence of ADH, then what will happen? The hyperosmolality which is present over here, it will pull the fluid, water outside. Because it is now water leaky. Because it is water leaky, now hyperosmolality of this area will pull the fluid to interstitium. And as fluid is moving out into interstitium, urine is getting concentrated. So really, what determines will pass diluted urine or concentrated urine is the presence of ADH over here. Is that right? Again, let me repeat the whole story. Okay, you would like to understand in the small diagram or large diagram? Hurry up. Large diagram. Look, it's mother diagram, that is daughter diagram. I think granddaughter diagram. Now listen. Again, under all circumstances, this part of the nephron is water permeable. All physiological circumstances. Under all physiological circumstances, this part of the nephron is water tight. This is water leaky. This is water tight. And this area will be water tight or water leaky. It depends on ADH is there or not. Am I right? So, and fluid is another thing. This part is constantly throwing solute out. So it is making the medullary interstitium highly concentrated. And some urea is also cycling from here to make it highly concentrated. Now, as filtrate is formed, it is isotonic with the blood. And this part, right, proximal capacity, solutes and water are absorbed in the same ratio. So fluid remain isotonic. But as, even though this area is fully permeable to water, as well as this is fully permeable to solutes. So what really happens, as this fluid is going down, right, it is going into interstitium. This tube is, you can say, progressively entering into interstitium, which is hyperosmotic. So it will keep on losing water, keep on gaining solute. So by the time tubular fluid reaches hairpin turn, it is highly concentrated. And then it starts turning upward. Now it is moving from medulla to cortex, right? And when it is moving upward, suddenly the cells become impermeable to water, but they keep on throwing the solute out. So we say, as this fluid is moving through the thick part of ascending limbo loop of Henle and early part of distal convoluted tubule, the tubular fluid become progressively diluted. So we call this also diluting segment. So everyone makes the urine, tubular fluid highly diluted up to this point. After that, what determines the urine which you are passing, it will be diluted or concentrated? This factor will be controlled by ADH. This is the ADH which is released by the posterior pituitary gland, and you know the osmoreceptors in hypothalamus which determine the osmolality of the blood. If blood is hyperosmolar, osmoreceptors will give order to release ADH, and ADH will come and make these cells highly permeable to water. So when this will dip into progressively more and more hyperosmolar interstitium, hyperosmolality will pull the water out of luminal area, and what really happens, the urine passed is highly concentrated. If blood is hyper concentrated, urine will be also hyper concentrated. If blood has a little increase in osmolality, urine will become highly concentrated, so that water should be conserved in the body. But let's suppose if you take 10 glasses of water, you are trying to little bit reducing the osmolality of the blood. Blood osmolality go little down. Osmoreceptors inhibit the production of release of ADH. Your ADH become less. What really happens? The last part of the nephron becomes water impermeable, and then whatever diluting urine you are making up to this point, right? Hyperosmolality cannot pull this water out, and you will pass a lot of water, right, with dilution or with hypotonic urine, or we can say that urine will be totally dilute urine passage. Is that clear to everyone? Now we will be discussing a very special function which is performed by the cells in the thick part of ascending limb of loop of Henle. As you know, like all other cells in the nephron, these cells also have on the basolateral side sodium potassium ATPases, right? This is something present in all nephron cells, and as you know that these sodium potassium ATPases are actively transporting sodium out of the cell and pumping the potassium into cells. For every 3 sodium it pumps out, it pumps 2 sodium N, potassium N, 2 potassium N. So in the end, cell become poor in sodium and cell becomes relatively rich in potassium. Right? Now this is same which happens in every cell in the nephron. All cells are throwing sodium out of the cell on the basolateral side and accumulating potassium. But there is something very special which happens on the luminal side. On the luminal side, there is a very unique type of transporters, right? There is a very unique type of transporter, and what is the uniqueness about it? The uniqueness about this transporter is that this transporter actually transport 2 cations in along with 2 anions. Now cations which it transports in is sodium, and along with the sodium it throws in potassium, and along with that it takes up 2 chloride, not 1 but 2 chloride. That is why this is called, the name of this particular transporter protein, which is integral protein in the luminal membrane of the thick part of ascending limb of loop of Henle. This is called sodium potassium 2 chloride. Look, this should be called sodium potassium 2 chloride transporters. 2 chloride transporters. So we should call them sodium potassium 2 chloride transporters. Let's put this thing, please focus here, that we will make this here as a in our key. Right, it is sodium potassium 2 chloride co-transporter. Now, this is a very unique type of protein. This is very unique type of protein which is expressed on the luminal side of the ascending limb of loop of Henle, and to some extent in early part of the distal convoluted tubule. What is the function of this? It is taking up cations from the luminal fluid as well as anions from the luminal fluid. So it is taking positively charged and negatively charged solutes and concentrating them into the cell. Is that right? But this cell does not allow the water to move. Does this allow the water? So all these cells which are present on this side, due to the presence of sodium potassium 2 chloride proteins or co-transporters, or we call it symporters, they are constantly taking sodium, potassium and 2 chloride from the luminal fluid to the cell. Now, whatever sodium comes in, right, this will go out of the cell due to the presence of, yes, sodium potassium ATPases. So there is no problem. The sodium will be eventually coming out, and this sodium will add to the hyperosmolality of interstitium, right? What about chloride? Chloride also has special transport mechanisms on the basolateral membrane, so this chloride will also go out. So we can say that these cells are constantly taking sodium and chloride from the luminal side, right, and through the cell, eventually they are thrown into interstitium through the basolateral membrane. When sodium and potassium, sodium and chloride come into this side, naturally it will contribute to the hyperosmolality in interstitium. But there's a very special remarks we should make about potassium. Potassium is a funny thing. That something is happening very strange here. The potassium is being pumped from the basolateral membrane into the cell, and it is also being transported from the luminal side into the cell. So cell become progressively very, very rich in potassium. Cell is becoming very, very rich in potassium. Now, when so much potassium will accumulate into cell, then naturally we should have some escape mechanism for it. You will be surprised. Nature has provided us special type of potassium leaky channels on the luminal side. So potassium which has gone from here in, the potassium which has gone from here in, it will recycle and escape out. So what really happens? That these sodium potassium 2 chlorides are constantly taking sodium potassium and 2 chloride molecule ions from the luminal side to cell. Sodium and chloride will escape out, but potassium is accumulated into cell. Not only from the luminal side, but sodium potassium ATPases from basolateral side are also pumping the potassium into cell. The cell become very high into potassium. Potassium escapes on the luminal side through potassium channels, and because this area become rich in potassium, so this will become electropositive or electronegative. Electropositive. So we say this part of the nephron on the luminal side is electropositive. This part is electropositive. Now you may be thinking, what's the fun in knowing that it is electropositive or negative? What is its importance? Let me tell you something very important. Actually, when potassium again and again comes out, potassium becomes very rich in this area. When it becomes positively charged, then any other divalent cations, please concentrate here, that what really happens, that sodium was coming from here, sodium was coming from here, potassium was coming from here, chloride was coming from here. We have learned that sodium and chloride have gone to this side. Potassium has recycled back. And this potassium is responsible to keep this area electropositive. This is keeping this part of the luminal membrane side electropositive. But not only these things are coming, but lot of calcium and magnesium is also coming here. Calcium and magnesium are called divalent cations. They are called divalent cations. Now imagine, when calcium and magnesium, they enter into this part of the lumen, and they find that wall of the lumen everywhere is electropositive. When they find this is electropositive, you know that positive repel positive. So because potassium is forcefully coming out, can calcium and magnesium stay into this fluid? No. So they escape through gaps in between the cells. So when this calcium and magnesium rush out through the gap, you can say junction present in between the cell, we say they are not going through the cell, they are going in between the cell. Or we can say calcium and magnesium are reabsorbed not through the cell, they are reabsorbed from the side of the cell. So those substances which pass through the cells, we say they are going through transcellular transport. That is called transcellular transport. But calcium and magnesium has gone in between the cell or from the sides of the cell, so we say their absorption is paracellular transport. So what did we learn here? We have learned sodium, potassium and chloride, they are going through, especially sodium and chloride, in this part of the nephron is reabsorbed through transcellular route. But because potassium leaks back, recycles, right, this potassium makes the membrane of this luminal side electropositive. And this electropositivity, due to the abundant presence of potassium, makes the, you can say it repels calcium and magnesium. So when calcium and magnesium through the tubular fluid reaches here, it finds that luminal surface of the tube is electropositive. So they escape out of the luminal area to the interstitial area through the, yes, through the paracellular route. Am I clear? Is it clear to you? Now we'll concentrate on one more thing. And what is that? We'll talk about that if we apply a drug which really block this system. If we apply a drug which will block sodium potassium 2 chloride, what really happens to the whole dynamics of urine formation and other changes in the body? Now, do you know the drug which can block this? The drug which can block here, there is a drug, that drug is partly filtered from here, partly it is actively transported. And this drug will come along the lumen. And along the lumen, this drug will reach here. Again, let me repeat it, that the drug, for example, that drug we have taken parenterally or we have taken orally. Once it comes into your circulation, it will go to the renal system. Part of it is filtered, but a lot of it is actively transported by the proximal convoluted tubule and secreted into lumen. This drug will be moving along the nephron, and when it reaches here, it will find sodium potassium 2 chloride. And this drug loves the sodium potassium 2 chloride. So what will happen? This will hug the sodium potassium 2 chloride. And this drug will, when capture sodium potassium 2 chloride, what really happens? I'm going to explain. Right? This is the drug. And it has captured? Yes. What is the name of this drug? This is a very special drug, and it is sticking to the sodium potassium 2 chloride, especially with that domain we take the chloride in. And once this drug sticks with it, once this drug sticks with this, what really happens? That now, yes, you have to tell me. Now what will happen? That when sodium potassium chloride has this drug attached with itself, the sodium potassium 2 chloride cannot transport the, it becomes non-functional. When sodium potassium 2 chloride becomes non-functional due to the presence of this drug, right, there will be changes. But first, what will be the changes? Before we really discuss, I would love to know that what is the name of this drug. Yes, please. Yes, please. What is the name of this drug? Yes, please. Furosemide. This is a whole loop diuretics. It may be furosemide, it may be torsemide, it may be bumetanide, or it may be ethacrenic acid. Right? All these substances basically make the sodium potassium 2 chloride dysfunctional on the luminal membrane of the cells which are present on thick part of ascending limb of loop of Henle. So this is how furosemide work, or loop diuretics work. Right? Now when loop diuretics work over here, right, what really happens? They make this non-functional. Now what will be the result? Listen. Result will be there that sodium cannot come in, potassium cannot come in. Is that right? And chloride cannot come in. End result will be this part of the nephron is unable to take up the solutes, cations and anions. So sodium and chloride are not transported from this area to the interstitium. Sodium chloride will move forward. So in the presence of this drug, the amount of sodium and chloride which is going to more distal part of the nephron is less or more? More. Is that right? Sodium chloride load is going to the more distal part of the nephron. Am I clear? This is one thing. Second problem is there that once sodium and chloride are not allowed to absorb from here, it means they are not coming to interstitium. Interstitium will become less hyperosmotic. Interstitium will become less hyperosmotic, and even urine will become less dilute. Urine will become less dilute. Now, when sodium chloride will reach over here, what will be the result? As you know from previous discussion that a lot of sodium which is going down, some of it will be extra sodium which come here. This extra sodium will be transported to principal cells of collecting tubular system. Now, as you know, these cells like other cells are also sodium poor. Normally what happens? About 60 to 65% of the sodium is reabsorbed from this part. And about 25% of sodium is reabsorbed from this part. About 8 to 10% sodium is reabsorbed from this part, and only 2 to 3% sodium is, very little sodium is reabsorbed from this part. So it means that 25% of the sodium is reabsorbed from here, sodium and chloride. If you apply a drug over here, it will allow a lot of sodium and chloride to move forward. And this lot of sodium and chloride, when it will move forward, more distal part of the nephron cannot really recapture it. Because more distal part of the nephrons cannot recapture it, so lot of it really appears into urine, and there is a lot of sodium and chloride which is going into urine, dragging the water along with it, and they will produce mild diuresis or heavy diuresis. They will produce heavy diuresis and heavy natriuresis. But as a lot of sodium is going forward, some of the sodium will be taken up by these cells, and when this sodium is going in, this sodium will go out to sodium potassium ATPases. When this sodium will go out to sodium potassium ATPases, of course they will bring in more potassium, and when they will bring in more potassium, then potassium leakage from the cell to the luminal side will increase. So it means that sodium which is reaching here, it is getting exchanged with the potassium. So it means not only it produces natriuresis, but it also produces Kaliuresis. It will also lead to the potassium losses, as we discussed in previous lecture. One more thing which I would like to highlight, that this sodium which is going down, right, it has dragged the water with it, and of course because it is electronegative, chloride is also coming here. The chloride which is coming here, this is making this area more electronegative. As I told you, this part of the nephron was electropositive, this part of the nephron is normally electronegative. I will explain later why. And when chloride come over here, it becomes more electronegative, and enhanced electronegativity in the lumen further enhances the escape of potassium from the cell to lumen, and Kaliuresis is further increased. So Kaliuresis is due to exchange of sodium from the principal cell. Kaliuresis is because anion load on the luminal side of principal cell is increased, and anions attract the potassium from the cell to lumen. Is that right? Another point which I want to highlight, attention please. I said when furosemide is biting on this and inhibiting this, sodium will not be reabsorbed. What else will not be reabsorbed? Chloride will not be reabsorbed. If sodium and chloride is not reabsorbed, they will be going distally. Number one, that will result in natriuresis. Number two, sodium exchange in the principal cell will bring in more Kaliuresis, and anion present here attract the positive cations from the cell, again Kaliuresis. But we did not discuss an extremely important point. The extremely important point was that when this drug is applied here, not only sodium and chloride are not reabsorbed, actually potassium is also not reabsorbed, because it was sodium potassium 2 chloride transporter. So when this transporter fail, not only these cells fail to take up the sodium, and not only they fail to take up chloride, they also fail to take up potassium. When potassium is not going in, it means intracellular potassium levels go down. It means potassium which is leaking to the lumen will be more or less? Less. It means when you apply the furosemide here, potassium cycling from the lumen to the cell is less. It means from the cell, recycling to the lumen is also less. So what really happens? The electropositivity which is present here will decrease, and this area will become less electropositive. Please listen carefully. When this area will become less electropositive, what will happen? It will no more, you can say, push the calcium and magnesium or other divalent cations to escape through the paracellular route. Do you think if because it was the potassium recycling generated electropositivity which was forcing the divalent cation to escape through paracellular route? When furosemide is applied to sodium potassium ATPases, it is applied to sodium potassium 2 chloride system, not only sodium and chloride uptake is failing, but potassium uptake is also failing. When cells become poor in potassium, they are not leading to recycling of potassium to the lumen, and electropositivity on the lumen become less, and when electropositivity on the lumen become less, then calcium and magnesium are no more pushed through the paracellular route. So we can say reabsorption of calcium and magnesium through the paracellular route is decreased due to decreased electropositivity on the lumen, which is due to decreased potassium recycling, which is in fact due to decreased activity of sodium potassium 2 chloride transporter, which is actually due to application of loop diuretics. Now, if this part is not reabsorbing calcium and magnesium, the load of calcium and magnesium will go to distal part. Calcium will come over here in extra amount and magnesium as well. Is that right? Even though there is some parathyroid controlled calcium reabsorption in distal part of the nephron, but some calcium will be lost. So it means that there will be not only natriuresis, not only kaliuresis, but there may be calciuria and magnesiumurea. Is that right? So if someone is taking furosemide for long-term base, an old woman taking furosemide for a long time, what really happens? That excessive calcium losses are present in the urine for years and years. And even this little loss of calcium may eventually activate the parathyroid hormone to activate certain osteoclasts in the bones to release the calcium from the bone, and women may develop more accelerated osteoporosis. Is that right? This is one side effect. The loop diuretics loop out the calcium. Is that right? This is one point which is very important to know. And second point which is very important to know regarding this thing is that this has one therapeutic application as well. For example, if you have a patient who has severe hypercalcemia, one way to manage this patient is give intravenous furosemides. When a patient has severe hypercalcemia, you give him intravenous furosemide, then whatever calcium is filtered, right, the part of the calcium which was supposed to reabsorb from thick part of ascending limb or loop of Henle will not be reabsorbed, and you will produce heavy calciuria, so body will get rid of calcium. But remember one thing, that under these circumstances, person is not only losing the calcium after parenteral furosemide, he is losing sodium and chloride, and of course everything is dragging the water. So very rapidly person will become dehydrated. So, but if person is losing the calcium as well as water, calcium concentration in the blood will not change. Rather, we are putting the person to the dangers of dehydration. That is why such type of management, when we are giving furosemide to get rid of the calcium out of the body, we must give normal saline in abundant amount, carefully of course, along with the furosemide. So, the one of the management of hypercalcemia, when calcium level in the blood is very high, is give the parenteral furosemide along with normal saline, so that when the diuresis, natriuresis, kaliuresis and calciuresis start, person should not become dehydrated. Is that right? One more point which I would like to highlight is that when sodium is going more distally, if you are using furosemide for a longer time, what really happens? You will become dehydrated. Okay, we'll discuss that later. One more point which I want to highlight about these cells. These cells, some cells which are present over here, these are called intercalated cells. In collecting tubule, these cells are called, this was principal cell, and this is intercalated cell. Intercalated cells have a master function and regulation of acid-base balance in a special way. How? Actually, intercalated cells also have carbonic anhydrase, and they have a capability. Please focus here that intercalated cells also has carbon dioxide and water, and they have a very special type of, what is this? You remember your friend? Carbonic anhydrase, and they are capable of making what? Carbonic acid, right? And this carbonic acid dissociate into bicarb and protons, and these protons are there are special proton active transporter on the luminal side, and they are actively transporting these protons from the cell to the lumen. Is that right? They are bringing lot of proton from the cell into lumen. So it means this part of the nephron, by the virtue of presence of intercalated cell, is constantly secreting protons. And of course, during this process, it is making what thing? It is also making bicarb. And this bicarb is pumped to the blood. So it means intercalated cell provide the acid to lumen and provide the alkali to the body. Is that right? This alkali will react with the fixed acid in the body, right? And the proton will come here. And this proton, as you know, will react with phosphates. This proton usually react with HPO4 and make it H2PO4. Or this proton will react with NH3 and make it NH4 with chloride. And it means when protons are secreted more over here, extra protons are coming here, then in the urine, HPO4 concentration will go up and NH4Cl concentration will go up. It means urine will become more acidic. Urine will become more acidic. Having said all of this, now correlate this information with the furosemide. Actually, listen carefully. All the diuretics which bring more sodium over here, attention please, more sodium will move into cell. This area will become more electronegative. And more electronegativity will pull more potassium from the principal cell to the lumen, and it will pull more hydrogen from the intercalated cell into this area. So it means that when you're putting furosemide here, more protons are going to urine. It means urine is also getting more acidic. Or another way, if more protons are going over there, is that right? What really happens? More alkali is going over there. Is that right? Just hold on. Again, let me repeat it. That actually there are multiple factors. Number one, there is electronegativity developed, and it is pulling out not only more potassium into lumen, but it is bringing out more protons as well. This is one concept. Second concept which is relevant is that eventually this patient, if he's using diuretic for a long time, he will develop what? This person will develop eventually dehydration and hypovolemia, and renin, angiotensin, aldosterone axis will be activated. And when these cells, principal cells, are also sensitive to aldosterone. And aldosterone, as we will discuss later, it helps in retaining sodium and water, and it helps in expelling potassium and protons. So we can say furosemide by multiple mechanisms help in expelling of potassium and protons out of the body. So it makes the urine more acidic. And if urine is becoming more and more acidic unduly, then supply of bicarb from the intercalated cell to the blood will become more, and blood will become alkaline. Blood will become alkaline. Is that clear? So we can say that how many problems, how many alteration furosemide has produced? Number one step. Now let's recap everything. Number one, furosemide should be present in the luminal side because its target proteins are on the luminal side. That is why whatever furosemide is filtered or actively secreted by proximal convoluted tubule, it will pass through the loop of Henle. When this loop diuretics are coming into loop, ascending loop, then they will bind with the sodium potassium 2 chloride system and make it dysfunctional. Then sodium chloride cannot be taken up by this part, so there will be natriuresis. Along with that, chloride will be lost, right? And of course these two things will pull water, and diuresis will be also there. Then I told you when sodium is going more to the distal part of the nephron, near the intercalated cells and near the principal cells, it will drag more potassium and protons into the luminal fluid. So that will end up into not only natriuresis, not only excessive loss of chloride, but also kaliuresis and also acidic urine. Is that right? Along with all these things, we have seen that not only sodium and chloride is not taken up by these cells, but potassium does not enter into the cell. So cells don't have enough potassium to recycle to the luminal side. So luminal side, when it does not get potassium from the cellular side, its electropositivity is reduced. Under reduced electropositivity, the luminal side of these cells cannot push the divalent cations through paracellular route. So calcium and magnesium absorption is reduced. So they are, you can say, delivered to more distal part of the nephron, and urine will become, so some degree of calciuresis may also develop, and some degree of chronic magnesium loss with chronic use of loop diuretics may also develop. right? Now we will be talking about how the thiazides work, right? Thiazide diuretics and thiazide-like diuretics, they work primarily on the distal convoluted tubule. Now first we'll see how this cell in the distal convoluted tubule normally works in sodium handling and calcium handling. Then we shall see that how when the drug thiazides or thiazide related drugs are applied, what are the alteration in whole function of the cell. As like other cells, these cells also have sodium potassium ATPases abundantly present on the basolateral membrane. So naturally they will be also pushing out the sodium out of the cell, and they must be accumulating the potassium within the cell. So they are also accumulating potassium within the cell. Now, naturally the result of this situation is the cell becomes rich in sodium, but it becomes poor in sodium and rich in potassium. Let's suppose this is a cell which is poor in sodium. Now, larger amount of sodium is coming here. Again, I will repeat that if there are 100 units of sodium which are filtered over here, about 60 to 65 are reabsorbed in proximal convoluted tubule. A small amount is reabsorbed, about 5 to 10% from loop, descending part of the loop. The ascending part of the loop is responsible from 25 to 30% of the sodium reabsorption, right? And here you should remember why furosemide is so important, because they're working on a part of the nephron which reabsorb really large amount of sodium. And secondly, when they don't allow the sodium to be reabsorbed and sodium is delivered to the distal part of the nephron cannot handle that much sodium, so they will lead to massive diuresis. But by the time sodium reaches distal convoluted tubule, right, and earlier part of the nephron are working normally. If earlier part of the nephrons are working normally, then most of the sodium has been reabsorbed. Only 10 to 12% of the sodium comes here. Usually around 8% sodium is normally absorbed from distal convoluted tubules. Maybe 2 to 3% is reabsorbed by the principal cells in collecting tubules under the influence of aldosterone. Now, let's concentrate on this particular cell in the distal convoluted tubule, that how it leads to sodium reabsorption. As we were saying that these cells, like other nephron cells, are having a lot of sodium potassium ATPases in the basolateral membrane. So these cells are constantly pumping out the sodium to the extracellular area through the basolateral membrane. So these cells are sodium poor. So naturally there is electrochemical gradient from the lumen to the cell for the sodium. But as you know, sodium cannot dissolve again into these membrane. They require special transport mechanism. The transport mechanism here for the sodium is bit different. This transport mechanism for the sodium here is, this is the transport protein, and this protein which is taking up sodium here, it is actually co-transporter. It will always transport sodium along with chloride. It will transport sodium along with chloride. So you can say that these cells of the distal convoluted tubule, face of the cells, they are loaded with So we were talking about sodium chloride co-transporter present on the luminal face of the distal convoluted tubular cells. These are integral proteins or transmembrane proteins. Whenever they are taking the sodium along the electrochemical gradient from the lumen to the cell, they will take some chloride as well. There are chloride channels present on the, what is this side? Basolateral side, and chloride will eventually go to the interstitial fluid and back to the body. Now, what about the sodium? How the sodium is going to get out of the cell? One route of the sodium is that it is going through sodium potassium ATPases. But one thing which I want to highlight, these cells are also responsible for absorption of calcium under the influence of parathyroid hormone. Let's see how parathyroid hormone is operating over here to handle the calcium absorption in this particular cell. What really happens, as you know, parathyroid hormone is a peptide hormone which is secreted by chief cell, the parathyroid gland. And parathyroid hormone work on their specialized receptors, serpentine receptors. This is parathyroid hormone which is applied on this area, and when parathyroid hormone stimulate this particular receptor, this receptor will give intercellular signal. The result of the signal is that on this side, what is the side? Luminal side, right? On the luminal side, there is an insertion of calcium channels. There is insertion of, yes please, calcium channels. Let's suppose this channel is for the calcium channel. And at the same time, there are special type of exchangers present on basolateral membrane, and these exchangers are sodium calcium exchanger. Sodium, which has to go this way, sodium, but along with calcium, and calcium has to go that way. Now what really happens? Look, normally these sodium calcium exchangers, which are again special type of proteins in the membranes, they are constantly taking the sodium in and taking the calcium out from the cell to the circulation. But during this time, whatever sodium is coming in, of course, that is being added to this sodium and pushed out through sodium potassium ATPases. But when cell become poor in calcium, if there is any calcium passing by this area, this calcium will be taken up by, pulled into the cell, and naturally this will go out through that exchanger business, right? So we can say that absorption of calcium, now let's focus from that area up to this area, right? That calcium absorption from the thick part of sending loop of Henle is a different way, and calcium absorption from the distal convoluted tubule is in a different way. Calcium absorption from the thick part of ascending limb of loop of Henle is due to electropositive luminal side, which is electropositivity which developed due to recycling of potassium, and which produces so much positive ionic you can say charges here, that divalent ions like calcium and magnesium pass through paracellular route from the lumen to the interstitial fluid. The point which we have to highlight here, that this movement of calcium and magnesium, or especially calcium, this is not dependent in this part of the nephron on parathyroid hormone. So we can say this is parathyroid independent absorption of the calcium, and that is the parathyroid dependent absorption of the calcium. When we come to this cell, this is the parathyroid hormone which stimulates its receptors, and these receptors give intercellular signal which increase the calcium channel concentration on the luminal side, and calcium sodium exchangers on the basolateral side. Now let's see, when we apply a special type of group of drugs which are called thiazide drugs. When these thiazide drugs are applied, what really happens to this particular part of the membrane? Let's suppose this is the new drug now, and this drug is, yes, yeah, this is the drug, and this drug is thiazide drug, right? It may be hydrochlorothiazide, it may be thiazide-like drugs. Actually, these thiazide-like drugs, what they really do, these drugs basically bind with the, what is this? Sodium chloride co-transporters, or we call it sodium chloride symports, right? This was sodium potassium 2 chloride co-transporter. Now you have to compare this and that, so let's focus all of this area in our mind, right? So this is sodium potassium 2 chloride where furosemide works. So furosemide work in which area? Number one, it work on thick part of ascending limb of loop of Henle and early part of distal convoluted tubule. Thiazide work on cells of the distal convoluted tubule. Furosemide loop diuretic work on sodium potassium 2 chloride luminal transporters or symports. Thiazide work on sodium chloride transporters. Then another thing, that furosemide are working in that area which absorb normally a very heavy load of the sodium, that is 25 to 35% of the sodium. This thiazides are working in that part of the nephron which absorb only 5 to 8% of the sodium. So naturally, when furosemide blocks its area, there is heavy natriuresis, and when thiazides block their area, there is mild, relatively moderate degree of natriuresis and diuresis. Then another important point was that when this sodium chloride transporter is blocked, of course these cells are not getting sodium and chloride, and this sodium and chloride is moving more, delivered to the more distal part of the nephron. When this sodium and chloride is delivered to the more distal part of the nephron, of course they're passing by the principal cells and they exchange the sodium with the potassium. So again it means thiazide diuretics will also lead to heavy losses of Potassium. Again, what are the reasons of potassium losses? One thing is very simple, because some extra sodium is delivered to the principal cells, and this sodium will go inside the cell, and these cells will use the sodium potassium ATPases excessively to push the sodium to the interstitial area back to the blood. During this business, they will bring extra amount of potassium into cell, and gradient of potassium from the cell to the lumen will become more, and potassium will be delivered more effectively to the lumen, and kaliuresis will be there. Second mechanism is that not only sodium is delivered extra to the principal cells luminal phase, but chloride is also not absorbed. So chloride is also delivered in extra amount to this area, and this chloride which comes over here, it makes the lumen more electronegative. When this lumen becomes more electronegative, then again chances of potassium to be attracted to the lumen and getting lost into urine are more. Then another point which is as well important, that this sodium and chloride, when these are delivered to the distal part of the nephron, along with sodium and chloride, water is of course going, and this water will increase, you can say, dilute the potassium, whatever potassium is present over luminal area. This extra water coming along with the sodium and chloride will wash away that potassium, and this concentration of potassium will fall into luminal area. So again, more potassium will shift from the cell to the luminal area due to enhanced concentration gradient from the potassium from the cell, principal cell, to the luminal area. So it means that, like furosemide, thiazides are also potassium wasting diuretics. Again, what we should say, that like furosemide, thiazides are also potassium wasting diuretics. Is that right? Now, what is really another important point to understand, that when you have applied the thiazides, of course, cell is not getting sodium. If cell is not getting sodium, now look at a very important point, that because sodium potassium ATPases are working, they have to expel the sodium out. So cell should get sodium from some side. Normally, cell gets sodium from the luminal side, where sodium and chloride enter, and cell gets sodium from the basolateral side from where sodium is coming into cell in exchange of calcium being expelled to the interstitium. Now, when the sodium supply from the luminal side to the distal convoluted cell cytoplasm has been reduced due to the blockage of the sodium chloride import due to thiazide, then extra sodium, sodium become very less in the cell, and cell gets extra sodium by overusing the pump. Which pump? Not pump, actually it should be called the sodium calcium exchanger. So more and more sodium is coming in, and of course when more and more sodium will be coming in through this exchanger, as sodium supply from this side has been blocked, so more and more sodium is coming from this side, then naturally more and more calcium will be going from the basolateral side to the blood side. And if extra calcium is going out, it means intracellular calcium become very less. So drag of the calcium pull from the lumen to the cell will decrease or increase? It will increase. So it means that when you are giving thiazides, then calcium is being absorbed at higher concentration or with higher avidity. So what we can say, this is a calcium, and this calcium is being absorbed more effectively by the distal convoluted tubular cells when we are using thiazide. What did we learn from here? The thiazides are calcium retaining drugs. Thiazides are calcium retaining drugs. Now it has some clinical implications. Number one, for some people, when there is idiopathic hypercalciuria, in some families there is a problem called idiopathic hypercalciuria, and these people, calcium reabsorption is not very effective, so extra loads of calcium are going to the distal part of the nephron, and naturally in these people this extra calcium plays a big role in formation of renal stones, especially calcium oxalate stones. Again, let me repeat it. What really happens in some people, there is a problem called idiopathic hypercalciuria, that these people are losing excessive amount of calcium into urine. Probably there is some problem with reabsorption of calcium in the nephron. So naturally when calcium is filtered freely but not reabsorbed well, so extra amount of calcium will appear into urine, right? When they are throwing more and more calcium into urinary system, the chances of formation of calcium related stone is high. So these people get again and again renal stones. One of the treatment in these patients is give low dose thiazides for a long time. When you are giving low dose thiazides, right, naturally when sodium is not entering from the luminal side, sodium will enter from basolateral side in exchange with the intracellular calcium to interstitium, and when cells become poor poor in calcium, the luminal side will take up the calcium from the luminal side into cell and then back to the body. So distal part of the urinary system will not get enough calcium to make stones more frequently, right? So now let's compare a very important point between the thiazide usage and furosemide usage and relationship with the calcium. Of course, every student knows that both of them are natriuretic drugs. Both of them are kaliuretic drugs. But very few and very good students know that both of them affect the calcium, but in an opposite way. That furosemide, once furosemide is there, calcium cannot be reabsorbed from the paracellular root of thick part of sending limb of loop of Henle. So what really happens that there is excessive loss of calcium. So furosemide is calcium wasting diuretic, or that is why furosemide sometimes can be used along with the normal saline for the handling of the acute hypercalcemic state, right? Opposite to that, thiazides, they don't waste the calcium, rather they retain calcium. And one interesting thing, they have seen that if thiazides are used for a long time, so calcium is so effectively retained in the body that osteoporosis is retarded, or bone mineralizations are, you can say bone mineralization or bone mineral density is maintained very well, especially in the hip bones or in the neck of the femur. So you can simply remember thiazides retain the calcium for thighs. Actually it is a little above the thighs, right? So thiazides retain the calcium for the thigh bones, but actually it is above the thigh bones, which is your pelvic bone, right? So we can say, and of course in the spine as well. So people who have been using, now listen, if there are two group of old ladies, if they are using, one group is using, first group is using furosemide on the long term basis and second group is using thiazides on the long term basis, you will find that over the long time, the group with the furosemide use will have accelerated osteoporosis, and group which is using, you can say thiazide for a long time, their even normal age related osteoporosis will be retarded, right? Is it clear to you? Now again, after having said all of this, let's compare furosemides with the thiazides. Look, furosemides work at thick ascending limb of loop of Henle mainly. Thiazides work mainly on the distal convoluted tubular cells, right? Furosemide work on sodium, one thing common, furosemide work on the luminal side. Thiazides also work on the luminal side. Furosemide need to be filtered or secreted by the proximal convoluted tubule in the nephron tube, right? Thiazides also need to be filtered as well as actively secreted in the nephron lumen, because both of them have to go through the tubular fluid and work on the special integral proteins present on the luminal sides. Another point which is important is that furosemide and thiazides, both of them have their action dependent on prostaglandins, because prostaglandins are, now if you are taking some indomethacin or some other NSAID, then there is a chance that prostaglandin level goes down and both of them may not work well. Another point which is related here is that because both of them need to be secreted from the blood through the proximal convoluted tubule to the lumen, if furosemide, attention please, as I said that both of them, furosemide as well as thiazide, they work from the luminal side, so they have to be present in lumen, and this duty is mainly done by proximal convoluted tubular cells. We take up furosemide and thiazide from the blood side and pump them to lumen, right? Who are responsible to transfer of organic material and other compound drugs and penicillins and uric acid and many other substances from this side to that. Is that right? Now, here we should know that if someone has impaired renal function, then it's quite possible that furosemide or you can say thiazide may not reach into lumen in enough concentration, and under these circumstances there will be loss of diuretic function in patient with failing renal system. Another related point is, as I'm trying to stress, that furosemide and thiazides, they must be taken from the peritubular system, capillary and interstitial system, and by the proximal convoluted tubular cells. These drugs should be actively transported or secreted, you can say, to the lumen. So this pathway is shared by the this pathway is shared by the uric acid as well. So it's very easy to understand that if you are using these drugs chronically, then naturally if this pathway transport, proximal convoluted tubular transport pathway, which is for organic acids and bases, right, if that is utilized by these drugs for transportation, then our uric acid may not be transferred properly from the blood to the lumen. So this may end up into hyperuricemia by both of them. So again, I will repeat it, that furosemide and thiazides both work on the luminal side. Both of them work on the integral proteins which are concerned with sodium absorption. Both of them are they produce natriuresis. Both of them produce diuresis. Both of them produce kaliuresis. But a very, very important point: loop diuretics waste calcium, and your you can say thiazides retain calcium, right? This is a very big difference which I would like to stress upon even 1,000 times, but I'm going to excuse you right now. So let's go ahead. But there are still many differences. What are the differences? This is working on thick ascending limb of loop of Henle, that is working on distal convoluted tubular cell. Furosemide is working on sodium potassium 2 chloride co-transporter, and this is working, thiazide is working on sodium chloride transporter. Furosemide is helping in preventing the reabsorption of calcium, right? And thiazide is enhancing the reabsorption of calcium. Furosemide is a strong diuretic. Thiazide is mild to moderate diuretic, right? Now, after having said all of this about thiazide's mechanism of action, let's go and discuss some more diuretic drug. Up to now, the drug which we have discussed are, again, let me repeat it. We have talked about carbonic anhydrase inhibitors, which were primarily your acetazolamide, which was working on proximal convoluted tubule. Then we have talked about furosemide. Then we have discussed about thiazides. The common thing in all these three drugs was that all these drugs increase the load of sodium to the principal cell's luminal phase, and all of these drugs increase the load of anion to you can say principal cell's luminal phase, and all of these drugs increase the flow of the tubular fluid on the luminal phase of the principal cells. So due to these reasons, all of these drugs are potassium wasting drug or kaliuretic drugs. But any diuretic which work distal to that point, that is anti-kaliuretic diuretic drug. Now we will be talking about the role of principal cells in handling of sodium and potassium, right, and how these cells are influenced by the aldosterone. Actually, what really happens, principal cells which are present in distal part of the distal convoluted tubule, and principal cells are also present in the collecting tubules. They are very important cells. That most important point which they do is that they are main potassium secretory cells, right? They are all the time matching the potassium secretion with the potassium intake. You know, we are taking a lot of food, and that food, a lot of potassium is there, and we are not measuring the potassium content of the food. So potassium is being loaded from the GIT to the body randomly, sometimes more, sometimes less. But potassium levels in the blood should be kept in a very narrow range. So whenever we take extra potassium, that it is the responsibility of principal cell to get the extra potassium out, right? In the same way, they are also concerned with retention of a little bit salt and water, right? Let's see how do they really work. Like other nephron cells, principal cells are also loaded with the sodium potassium ATPases on the basolateral side. So naturally, principal cells, like the other nephron cells, they're also constantly pushing out, you can say, pumping out sodium from the cell to the interstitial area. And for every 3 sodium they expel out of the cell, they bring how many potassium? 2 potassiums, right? So naturally the result is the same, that cells become poor in sodium and rich in potassium. These cells, like other nephron cells, they are poor in sodium and rich in potassium. But these cells in the luminal phase have different type of channel system than other cells in the nephron. The unique point is here that on the luminal sides they are having unique type of sodium channels and potassium channels. Please don't confuse these sodium channels with other sodium handling proteins present in the nephron. Let's recap all the sodium handling proteins in the nephron. Let's focus on the all nephron, right? Come here. There are some proteins. Look, one thing you should know, that sodium is extremely important to be conserved in the body, and sodium handling should be very, very sensitive, because sodium is freely filtered along with many other substances, right? And if it is, for example, if sodium balance cannot be controlled in the body, the real trouble is with extracellular fluid. The volume of extracellular fluid in your body is mainly dependent on sodium and chloride level, or sodium level, you can say, which determines chloride with it. Now, let's suppose if I retain a lot of sodium, then my extracellular fluid compartment will expand, right? And that may lead to pulmonary edema or other type of edemas. Or if my sodium level in the body go very down, that will lead to what? A dangerous shrinkage in the extracellular fluid, including the vascular compartment and cardiovascular collapse. So it's very important to maintain the sodium level in the body properly. One of the major functions of kidney is to regulate sodium level as well. As we know that sodium is freely filtered from here, but sodium is very, you can say, precious to us. So whatever sodium is freely filtered, most of it should be reabsorbed by the nephron cells and taken back to the blood. Is that right? Now, different part of the nephron reabsorb the sodium in different way. For example, in proximal convoluted tubular cells, which are responsible to reabsorb about 65% of the sodium, right? There are multiple mechanisms for sodium reabsorption. One mechanism we have already discussed. Remember, sodium is not lipid soluble, so it cannot go easily from the luminal phase, from the tubular side to the cell, right? But once sodium is in the cell, all nephron cells have the same mechanism. All nephron cells are loaded with the sodium potassium ATPases. If somehow from the luminal side we can take the sodium into the cell, right? Once sodium is inside the cell, sodium potassium ATPases will expel from the basolateral membrane this sodium to the interstitial fluid, and sodium will go back. So problem is not how you get the sodium from the nephron cells to the interstitium. Problem is how to get the sodium from the lumen side or tubular fluid into the cell, right? Now different cells have different strategies which are sodium capturing strategies, which are used by the proximal convoluted tubules are multiple. Number one, to capture the sodium, they are having, number one mechanism is sodium proton antiport or sodium proton counter transport, where every sodium molecule which is taken by this protein down the electrochemical gradient, it secrete one proton in the lumen, which help us to reabsorb bicarb. Secondly, sodium is reabsorbed along with glucose, or rather more true statement should be glucose is reabsorbed along with the sodium. So there are, you can say, sodium glucose co-transporters, then there are sodium amino acid co-transporters, then there are sodium chloride co-transporters. Even some people believe there may be some sodium phosphate co-transporters which are inhibited by the presence of parathyroid hormone in the proximal convoluted tubule. Now, so these are different mechanisms of sodium reabsorption. Here I would like to give very important concept. As you know that maximum amount of sodium is reabsorbed by proximal convoluted tubule, and sodium is reabsorbed in proximal convoluted tubule in the maximum in sodium chloride form. So if we have a diuretic which can block the sodium chloride from the proximal convoluted tubule to reabsorb, that will be the most powerful diuretic in the world. Presently we don't have any safe drug like that, right? Anyway, we have a weak drug, acetazolamide, which will block the sodium proton antiport, right? Then in this part, descending limb of loop of Henle, sodium actually does not go out. It is actually taken up by the hyperosmolar interstitium, right? So we cannot talk about the descending limb of loop of Henle is concerned with sodium reabsorption. Rather, it is descending limb of loop of Henle is losing the water and gaining the sodium, right? Then we talk about the ascending part of the loop of Henle. Thick ascending part of the loop of the Henle, main mechanism for reabsorption of sodium was from the luminal side. Absorption of sodium was mediated by sodium potassium 2 chloride, which are affected by furosemide. Then we go more distally. In distal convoluted tubule, sodium is reabsorbed by sodium chloride co-transporter, right? And this is affected by thiazides. Then by this time, only there is 3 to 4% sodium left in the tubule, and that is to be reabsorbed from the principal cells. So fine regulation, how much sodium will be really allowed to go into urine, is mainly done under physiological conditions by the principal cells. Now, how do the principal cells do? It's very simple. On basolateral membrane, like other cells, they also have sodium potassium ATPases. They are constantly expelling the sodium out and retaining the, pushing the potassium into cells. And due to function of the sodium potassium ATPases, like other nephron cells, principal cells are also deficient in sodium. So from luminal side, they will love to have the sodium. But you have to remember, like proximal convoluted tubular cells, these cells do not have sodium proton antiport. Like thick ascending part of limb of loop of Henle, these cells do not have sodium potassium 2 chloride system, so they cannot be affected by loop diuretics. And like the other cells of distal convoluted tubules, they do not have sodium chloride co-transporter, so they cannot be affected by thiazides. But they have a very unique mechanism. They have not transporter, they are having a channel. Remember, channel and transporter is a different thing. When sodium binds with the transporter undergo the conformational change and push the sodium in. But channel has a central pore, aqueous pore, through which the sodium goes in. So the aqueous pore planted in the luminal membrane of the principal cells, which are responsible to take the sodium from luminal side to the cell, and they are responsible, some more channels, they are responsible to take the potassium from the cell to the lumen. Now this sodium channels, right, these can be blocked by the drugs which are called triamterene. They can be blocked by the drugs which are called triamterene, and they can also be blocked by a drug which are called amyloride. These are special type of, you can say, sodium channel blocking drug. But please remember, these are not the voltage gated sodium channels. These are not voltage gated sodium channels. These are different type of sodium channels which are unique to these areas especially, and some other parts of the body also. So triamterene and amyloride can block these channels. Right. Now once these channels are blocked, what really happens? But before we really go, once they're blocked, we talk about the normal function. So what is normally happening to these cells? Look, normally sodium is, a small amount of sodium is reabsorbed from here. So it means, but you know, chloride is not allowed. Now look the beauty. Compare here. Here if one cation go in, one cation come out. So electrically membrane remain neutral. In this area, two cations are taken in, sodium and potassium, and two anions are taken in. That is chloride. So again it is neutral, but due to recycling of potassium, this area become electropositive. Here cation and anion, sodium and chloride are co-transported. So again there is no electrical problem across the membrane. Here sodium is taken in without any anion. When cation is taken in, we don't take any anion with it, right? Due to this reason, as sodium keeps on moving into this cell, under the concentration gradient, that sodium is higher in the lumen and less in the cell, as it is being expelled from the cell by the active transport. As sodium is entering into cell, it leaves behind electropositivity or electronegativity. Electronegativity. This concept is extremely important. Outside the luminal area of the principal cell, there's a lot of electronegativity. So this part of the lumen is electronegative. Now this electronegativity has two important roles. Number one, as we know that potassium is being accumulated into this area by sodium potassium ATPases, right? This electronegativity will attract the, yes, it will attract the potassium. So potassium will come into this area. So number one. Number two, you know, I told you that in the neighborhood of the principal cells, the intercalated cells which have a capacity to produce the protons and secrete the protons into proton ATPases into lumen. And again, if this electronegativity is maintained at high you can say number, then naturally protons are also attracted towards the lumen. What is this area? Lumen. So it means that electronegativity which is produced by the sodium influx into principal cell attracts protons as well as potassium into the lumen, and this leads to the acidity of urine as well as it leads to kaliuresis. Right? Now this is what is normally happening, and this mechanism is very, 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 very sensitive to aldosterone. Now let's see what is the role of aldosterone, how aldosterone can be fit into this situation. You know, when your body is depleted of salt and water, then naturally, you know, renin is produced. Renin convert angiotensinogen into angiotensin 1, and then you know that angiotensin 1 by angiotensin converting enzyme can be converted into angiotensin 2. And angiotensin 2 has many functions, but one of the functions of the angiotensin 2 is that it will go to the zona glomerulosa of adrenal cortex, and from there it will force the release of aldosterone. So we can say in salt and water depleted situations, body has a tendency to activate renin, angiotensin, aldosterone excess, and this excess produces a lot of aldo in the body. How this aldosterone work? Let's suppose here is adrenal medulla and cortex. In the adrenal cortex, we can say here is zona glomerulosa, and in this zona glomerulosa, under different influences, either there is more angiotensin 2, or there is less, or there is more, yes, potassium. Is that right? And many other factors, right? What really happens? This area releases aldo. Now, what aldo will do? Let's suppose this is aldosterone which is coming out. Now, what aldosterone is going to do? Aldosterone is lipid soluble substance. You know, it's one of the steroid derivative. It enters into blood, and from the which area? Basolateral membrane. Aldo will enter into cell. This is aldosterone, and this has entered into principal cells. Once aldo enters into principal cells, what it will do? Look here, it has multiple functions. Mainly, as this young boy was telling us, that aldosterone will bind with its receptors. And let's suppose this is the receptor of aldosterone. What is the function of receptor of aldosterone? When this receptor is bound with the aldosterone, this receptor becomes active. And this receptor, let's suppose we call this receptor aldo receptor. This is aldo receptor. Now this aldosterone receptor has one hormone binding domain and other DNA binding domain. So when aldosterone binds with the receptor, its DNA binding domain is activated, and receptor and aldo complex is translocated from the cytoplasm to the nucleus. Again, let me repeat it. Normally this receptor is present in cytoplasm, and if this receptor does not have aldo, then this part, which is, what is this part? DNA binding part is not active. DNA binding part is not active. But if aldo bind, this DNA part is activated, and immediately aldo along with what? Its receptor, it is activated receptor. This complex is transported to the nucleus. In the nucleus, what really happens? There are many genes which are activated by this complex. There are many genes which are activated by these complex. So we can say now aldosterone related receptor with aldo is going and activating this gene, and actually not one gene, it will activate many genes. Once these genes are activated, all of you know different kinds of what will come out? Messenger RNA, right? These messenger RNAs will be translated into proteins, and those group of proteins which are produced, right, messenger RNA will be translated into a full group of proteins. These are called aldosterone induced proteins. It means that if aldosterone is increasing in our body concentration, then this aldosterone will go to the principal cell, and in the cytoplasm aldosterone will bind with the receptor, and receptor with aldo complex will go into nucleus, translocated into nucleus. The nucleus, they will activate a set of genes and produce a huge, you can say, variety of different proteins in these cells. These are called aldo induced proteins. These proteins have multiple functions. Number one, look carefully now. What are the functions of aldo associated proteins? Number one, these proteins are, okay, let me tell you how they really work. Number one, these proteins will, sometimes some channels are active and some sodium channels are inactive. This is an inactive sodium channel. But when this protein will work on that, this protein will go into active state. So it means inactive channels will be converted to active channels. This is one thing. Number one, that aldosterone induced proteins are capable of activating the inactive channels in the membrane. So naturally, capability of luminal membrane to reabsorb sodium is increased. Number two, some channels are present within the cytoplasm, right? And this was mechanism number one. Mechanism number two, this will act on those channels and push those channels to the membrane. So not only it will lead to activation of the sodium channel, it will lead to extra insertion of sodium channel into membrane. So that will also increase the chances of sodium reabsorption. Is that right? Then third thing is that it will increase from this messenger RNA, this will increase the synthesis. Some of these messenger RNA will synthesize more channels. Is that right? And these channels will eventually also become the part. So what things up to now this has done? aldosterone induced protein has, number one, activated the inactive channels in the membrane, and whatever cytoplasmic store of channels are present, they have been planted and translocated to the membrane, and new channels have been synthesized. So this channel activation, sodium channel insertion, and sodium channel production, right? Once it has done these things, it means now capacity of the luminal side to reabsorb sodium is increased. But after that, you can say meanwhile, some of the aldosterone induced protein will work on sodium potassium ATPases. They will work on, yes please, sodium potassium ATPases. Again, mechanism will be number one, they will activate the sodium potassium ATPases and increase their efficiency more. So this was sodium potassium ATPase. Previously it was less active, and now under the influence of aldosterone induced, you can say, proteins, it has become superactivated. So as we said, it activates the inactive channels, it activates also the inactive sodium potassium ATPases. Number two, some sodium potassium ATPases which are maybe present within the cytoplasm, they are rapidly translocated to the basolateral membrane. So sodium potassium ATPases concentration become more in the channel. Number three, some of these, number six, that some of these messenger RNAs will actually translate into more sodium potassium ATPases. So again, three steps that we can say that aldosterone induced proteins have many mechanisms, right, to enhance the sodium reabsorption. Number one, these products can, number one, activate the inactive sodium channel on the make it like they work on the luminal side, they also work on the basolateral side. When they work on the luminal side, they increase the activation level of the already present sodium channel in the luminal membrane. Whatever channels are already present in cytoplasm, they have been also rapidly inserted into luminal membrane. And number three, there is excessive synthesis of sodium channels. So in this way, capacity of the luminal phase of the cell to reabsorb sodium has been significantly increased. Number two, they also work on the basolateral membrane to enhance its capacity to throw the sodium from the cell to the interstitium. They have to increase the whole work of sodium potassium ATPases. How this aldosterone induced protein do this work? Number one, they activate, further accelerate and activate the function of existing sodium potassium ATPases into membrane. Number two, if there are some sodium potassium ATPases in the cytoplasm, they are rapidly inserted into membrane. Number three, some of the messenger RNAs are translocated into more molecules of sodium potassium ATPases. Now, when basolateral membrane become overly loaded with sodium potassium ATPases, it means power of the cell to reabsorb sodium to throw the sodium from the cell to the interstitium has been increased. So from everywhere, sodium from basolateral membrane is rapidly going to the blood. And of course, every time more and more potassium is coming into cell. So it means the cell, by the superactivation of sodium potassium ATPases in basolateral membrane, cell has become extremely poor in sodium and extremely rich in potassium. And when it is extremely poor in sodium, whatever sodium is coming from here is very rapidly entering into cell, and you know that is being pumped to the blood. Right? In this way, the last amount of sodium can be retained by principal cells under the influence of aldo. But there is a problem. As more and more sodium is going in, this area will become more and more electronegative, and it will end up into two types of results. Number one, that this electronegativity will attract more protons. So it means that aldo will lead to loss of protons, as well as this excessive electronegativity coupled with more potassium brought into cell by the sodium potassium ATPases. Of course, the potassium which has come into interstitium, from the interstitium to the principal cell cytoplasm, that potassium due to concentration gradient is also moving towards lumen. At the top, electronegativity is also pulling it into the lumen. No, I think there is something. Yeah, you are right. So what really happens? This will lead to Kaliuretic. Is that right? This is the aldosterone mechanism. So in a nutshell, we can say aldosterone can retain sodium. Of course, water follows that. So we say normally aldosterone retains salt and water, and normally it help us to expel potassium and protons. Is that clear? Right. Having said all of this about the function of the principal cells, now we'll talk about how the different diuretic affect the function of principal cells. Right. Number one, in this category, there are a group of drugs which basically block the sodium channels present in the luminal surface. Right. There are only two important drugs in this group. Number one is amiloride, and this amiloride can block, you can say, these sodium channels. And second drug is, yes, triamterene, right? This can also block, you can say, this sodium channels. Once these drugs are applied over there, then naturally sodium cannot go in as conveniently. If sodium cannot go in, it will add to little bit natriuresis, remember, little bit, because normally this area reabsorbs small amount of sodium. So if you really block these, only 2 to 3% of the sodium, so block it, these channels, there will be very mild natriuresis. Along with that, of course, there will be some diuresis as well, right? And with these two things, when sodium is not going in, then naturally what really happens, that sodium potassium ATPases become slow, right? Because they don't have enough sodium to push it out. So naturally cells are not being pumped with potassium. So potassium level in the cell become less and rate of loss of potassium is reduced. It means these are anti-Kaliuretic drugs, or we can say these are potassium sparing drugs, right? As we have discussed, all the drugs which work proximal to this, they lead to potassium wastage. But this drug is potassium sparing drug, amiloride and triamterene, or you can say potassium retaining drugs or sparing drugs, or anti-Kaliuretic drugs. This is the role of amiloride and triamterene. But one important thing which is about this, that once you have blocked this area, it means sodium is left out. It means electronegativity cannot be maintained here. So another important mechanism is that when amiloride and triamterene block these channels, sodium cannot be absorbed into, so this area does not remain as negative as it is normally. So if it is less negative, again attraction for the potassium to come out of cell is also reduced. So that is the second mechanism how it acts as a potassium sparing drug. And in the same way, when it is reducing the electronegativity in this area, right, it will reduce the proton loss as well, and urine will be less acidified. Is that right? Then we come to another drug which is potassium sparing, or which is anti-Kaliuretic, but that drug is not blocking these sodium channels. That drug is actually structurally analog of, you can say, aldosterone, right? And that primarily binds with aldosterone receptor, right? That drug is called spironolactone. The name of the drug is spironolactone. Now this spironolactone, once you have taken this drug, what this drug is going to do? This drug is going into these cells, and once it enters into cell, this will take the place of aldosterone and it will bind spironolactone will bind over there. But this is a very important thing. Look, when aldo bind with this receptor, it stimulates its DNA binding region. But when spironolactone binds here, receptor is occupied by spironolactone, but its DNA binding portion is not at all activated. So what really happens, when you give more and more spironolactone will bind with aldo receptors, right? They have affinity to bind with aldo receptor, but these drugs do not have intrinsic activity to stimulate the receptors. So when aldo receptors are occupied by spironolactone, there are less receptors available for aldo, right? And spironolactone complexed receptors are not functionally active. So it means all the activity which is aldosterone dependent, that has been reduced. It means the capability of again luminal membrane to reabsorb sodium and capability of basolateral membrane to expel the sodium to the interstitium and bring the potassium into cell has been reduced. You know the mechanism. That what really happens when aldosterone dependent induced proteins cannot be produced. When spironolactone complexes with the receptor, then aldosterone induced proteins cannot be synthesized. So it means inactive channels cannot be activated. cytoplasmic channels, sodium channels cannot be inserted and new channels cannot be made. At the same time, sodium potassium ATPases cannot be further activated and cytoplasmic ATPases cannot be inserted into basolateral membrane, and new sodium potassium ATPases channel synthesis rate goes down. So all these things result into poor absorption of sodium by these principal cells. Unless sodium is going in, again remaining mechanism is clear, that this area will be less electronegative, right? And when less sodium is going in, more sodium is lost, mild diuresis, natriuresis along with diuresis. Secondly, this area will be less electronegative. When this lumen of this part of the nephron will be less electronegative, it will take less proton and urine will be less acidified. And secondly, because it is less electronegative, so drag on the potassium from the cell to the lumen is reduced. So potassium is spared in the body and it is not pulled to the urine. So this also works as anti-kaliuretic drug. We shall be discussing the mechanism of action of osmotic diuretics, that how osmotic diuretics produce diuresis. We will only do the mechanism of action, remaining detail will be done in later lectures. Right. The old concept was that osmotic diuretic primarily work on proximal convoluted tubule. The concept was based on this concept that they said that osmotic diuretics, let's suppose this is osmotic diuretic, these are large molecules, where these molecules, for example, these are mannitol molecules, they said that these molecules are freely filtered, and once they are filtered, they cannot be reabsorbed. So naturally, they said when these molecules are moving through the nephron tube, right, normally what happens, sodium and solutes and water is reabsorbed from proximal convoluted tubule. But because this solute cannot be reabsorbed, so they thought as the solute is moving forward, this will, as it is not reabsorbed by proximal convoluted tubular cells, so it will increase the osmolality in the luminal area. So it will prevent the further reabsorption of water and little bit salt as well. So that water, they said, osmotically will be dragged along the, what is this? Osmotically active agent like mannitol, and as mannitol is not reabsorbed, not secreted, so in the urine as mannitol will appear, right, it will pull extra water with it. Is that right? This was the theory in good days when you don't need to learn really much, right? But unfortunately, they have done some recent experiments and proved that there is some more important mechanism than this one, because they have seen that once you give the mannitol, delivery of water and salt from the proximal convoluted tubule to loop of Henle is not significantly increased, but after the use of mannitol, delivery of salt and water from, you can say, loop of Henle to distal part of nephron is significantly increased. So then they have to formulate a new theory and they have to think in different lines at how the osmotic diuretics work. Now, what is the latest concepts? Let's start from very fundamental aspect of osmotic diuretics. How do the osmotic diuretic work? Let's suppose we talk about the mannitol. Mannitol is given parenterally into, right, intravenously. Now this mannitol, this will appear into all the circulation, right? Plus it will go to extracellular fluid, right, interstitial fluid. Now when mannitol is given in large quantity, then osmotic pressure of extracellular fluid is more than osmotic pressure of intracellular fluid. So naturally intracellular fluid will start moving from the cell to the interstitium, and in this way result will be this, that intracellular fluid start moving from the cells to the outside. So we can say mannitol leads to expansion of extracellular volume. It leads to expansion of extracellular volume. When extracellular volume is increased, what really happens? The mannitol has led to increase in extracellular fluid volume. Now what are the results of this? It's very simple. Number one, this fluid will become less viscous. This will become less viscous. So renal blood flow will increase. Number two, when more extracellular fluid volume will increase, renin, angiotensin, aldosterone system will work more or less. That will work less. So vessels will not remain constricted, they will dilate. Again renal blood flow will increase. So why renal blood flow is increasing? It will lead eventually to increased renal blood flow. But what is the mechanism of increased renal blood flow? Number one is blood is less viscous, as lot of free water has moved from the cells and came into extracellular compartment and diluted the whole extracellular compartment. Number one. Number two mechanism is why renal blood flow increase? Because angiotensin aldosterone axis is inhibited. Right? When angiotensin 2 is inhibited, then angiotensin 2 does not keep the renal vessels constricted, especially efferent, and renal blood flow increases, especially to the vasa recta. Then another thing which happens, that even sympathetic tone also increases, because when extracellular blood volume or extracellular fluid volume is increased, then sympathetic tone is decreased. That also opens up those vessels of the kidney which are semi-constricted due to alpha-1 adrenergic receptors. So again, renal blood flow increases. Now, so what is the step number one in our concept? In the modern concept, step number one, when you give lot of mannitol, it will pull the water out of intracellular compartment. When this fluid shift will occur, then that will lead to increased renal blood flow. These are 2 points which we have explained. Then increased renal blood flow, what it is going to do with the kidney? Answer is that when there is increased renal blood flow, especially in medullary area, in the medulla, there is, what is maintained here? Interstitial hyperosmolality. So these are, now actually there is a lot of sodium chloride and urea present in medullary interstitium, and it is responsible to keep this area hyperosmolar. So and blood flow from this area is very, very slow. Why nature has kept the blood flow very slow through the medullary interstitium, through the vasa recta? Because nature does not want that fast blood flow washes away the solutes from medullary hyperosmotic interstitium. Again, let me repeat it. Kidney spends a lot of energy from thick ascending limb of loop of Henle to through lot of sodium and chloride in medullary interstitium to develop what? Hyperosmolality. Plus there is urea recycling. Urea is also accumulated in this area. So these two things together, right? That is sodium and chloride pumping from the thick ascending limb of loop of Henle to medullary interstitium, plus urea accumulation in medullary interstitium, both of them generate hyperosmolality in medullary interstitium. But once hyperosmolality is generated over this area, then it is maintained by vasa recta, which are very slowly moving the blood, and they don't wash away the solutes from this area. Is that clear? Now we, after this basic concept, correlate what mannitol has done. Pulled the water out of cells into extracellular compartment, right? And extracellular compartment, when it becomes really very rich, blood becomes less viscous, sympathetic tone goes down, renin, angiotensin, aldosterone, axis calm down. All these things increase renal blood flow, especially blood flow increases to, renal medullary interstitium. And when this blood flow significantly increases, it washes away the what? Solutes. When it washes away the solutes, it means its hypertonicity is reduced. When its hypertonicity is reduced, then what really happens, that when water is coming down, tubular blood fluid is coming down, it was medullary interstitium which could pull the water from the descending limb of loop of Henle out. Is that right? Now, because medullary interstitium is less, so pull on the water is less. So it means when pull of, number one, water is not moving from descending limb outside to interstitium. Number two, solutes are not moving from the interstitium to lumen. So it means now when it will go into ascending limb, do you think it's highly concentrated fluid going to ascending limb or relatively diluted? Relatively diluted, because it has not, while it was coming down, it did not lose the water and did not gain enough solutes. So when it starts going upward from medulla to the cortex, it provides the fluid, tubular fluid, to the thick ascending limb of loop of Henle, which is not as much concentrated as it should be normal. So what really happens, that thick ascending limb of loop of Henle cells work very poorly, so they are unable to extract salt and water, especially sodium chloride, from